The last session of the Gabriel meeting, the session on tuberculosis. But just before, I would like to remind you to leave your room at 9, so now. So if you have not done, please, you have to give the key at the reception desk. So it's my great pleasure to introduce the two chairmen of this session, Dr. Nestani Tugvadze from the National Center for Tuberculosis and Lung Disease in TDC, Georgia. She is the director of the TB Research Unit. And Dr. Delia Goletti, she is the head of the Translational Research Unit at the National Institute for Infectious Disease in Rome, Italy, and she has clinical duties in the lung infectious disease outpatient clinic. So please, can you?
Good morning. Can you hear me? Okay. Good morning. Can you hear me? Okay. So thank you to the Fondation Mérieux for having organizing this beautiful meeting, touching the different diseases affecting the world today. And it's a pleasure for me and for my co-chair to be the chair of this session on tuberculosis. And it's a pleasure to introduce Jonathan Hoffman, who is a dear friend and formally is the tuberculosis research manager within the medical and scientific department of the Fondation Mérieux in Lyon. And probably many of you has been knowing him in the past years, organizing several multi-center studies that produced important scientific achievements and also organized a better diagnostics and a better potential treatments for tuberculosis patients. So today he will talk to us about the roadmap and strategy on tuberculosis.
Thank you very much, Delia, for this kind introduction. Good morning, everyone. I'm very pleased to be there to open this session on TB. I would like to thank Florence Pradel, Marie-Charlotte Quémin for the organization of this beautiful Congress, and also all the Gabriel Network members who are here and who are participating in a TB project with us since 11 years so far. So I'm gonna present you the roadmap and strategy on TB. And so tuberculosis remains one of the top infectious killers worldwide, with approximately 1.5 million deaths per year, including the people living with HIV. And this tuberculosis is a major cause of deaths related to antimicrobial resistance. We are facing some challenges with several challenges with TB. We need more robust TB diagnostics that can be useful at different levels of the healthcare system. Especially, we need more robust TB diagnostic that can be decentralized from the reference center for an active and passive case detection. We also need TB diagnostics to identify people who are latent TB infection, who are progressing toward active TB. We also need a more efficient tool for drug susceptibility testing and also for treatment monitoring. Another challenge is the TB treatment. The TB treatment is very long, especially for MDR-TB cases, with a lot of adverse events, leading the patient to stop the treatment. And you have on this graph on the right, the treatment outcome for the MDR-TB cases. And you can see in green, the treatment success dropped to 57% among these people, and you have a higher rate of treatment failure and death and loss to follow-up in this patient. So we need shorter, efficient TB treatment and diagnostics to assess treatment outcome. Another challenge is a latent TB infection. We are approximately 2 to 3 billion people who are reported to be infected with Mycobacterium tuberculosis without any symptoms. And 5 to 10% of them will develop an active TB during their lives. So there is the TB preventive treatment, which is a solution to achieve the WHO and TB strategy, but the global progress in provision of this treatment lags behind. And you can see on this graph that only 21% of the targeted population received the TB preventive treatment the last 2 years. Also, COVID-19 pandemic and TB is a major challenge. The COVID-19 pandemic has caused enormous health, social, and economic impact on the provision and access to essential TB services. The TB cases notifications dropped and TB disease burden increased. So in that context, our mission is to increase access to diagnostics and strengthen lab systems, and also to build TB research capacities. Our general aim is to improve the diagnosis and management of TB among the most vulnerable population. You have here on this map the estimated TB incidence of TB. The darkest area relates correspond to the highest TB incidence. And you have on this map also all the Gabriel Network members. And in red, you have the sites that are collaborating or are doing some diagnostics or research activities on TB. And in green, you have the Rodolphe Mérieux laboratories that have been built since 2005 by Fondation Mérieux. One example is the Lebanon site that where the Rodolphe Mérieux laboratory became the national reference TB center, and thanks to the huge effort of the Lebanese team. In 2017, our aim at the medical and scientific department was to develop a clinical evaluation of active TB diagnostic tests. So we developed the INT project with 5 partners of the Gabriel Network, which is a multi-country evaluation of blood-based TB diagnostics for monitoring treatment efficacy. So this project has been done in collaboration with Delia Goletti and Giovanni Dologu. The main idea was to evaluate biomarkers for monitoring treatment outcomes. And we enrolled active TB patients at baseline and followed them across TB treatment. We evaluated different biomarkers, the white blood cell counts, and quantiferon TB Gold Plus, which is an IGRA, interferon gamma release assay. We evaluated a combination of 2 IGRA for monitoring treatment outcome. Also, we evaluated flow cytometry and a transcriptomic signature called RISC-6. We set up this project in 5 countries. We did site visit initiation and training, and we enrolled also 3 PhD students in this project. So our main indicators of this project. So we developed the first multi-country study on TB within the Gabriel Network. We enrolled 193 patients with TB disease that were followed up during TB treatment. We did 2 technology transfers, so IGRA and RISC-6 assay. We evaluated 4 diagnostic tools, and the key findings of this evaluation is that white blood cell counts may be a simple tool to help predict higher risk of treatment failure, which is very simple to do. Also, we show the relevance of IGRA for monitoring of pulmonary TB clearance, and we also show that blood-based RISC-6 signature is a powerful tool to identify subjects with active TB. So we enrolled 3 PhD students in this project, and we have published 3 papers so far. The results on RISC-6 led us to consider that this blood-based RT-qPCR assay might improve the childhood TB diagnosis. And we are conducting and developing a project which is called the DEDICATE project with our partner from Bangladesh aiming to evaluate this innovative blood test for the diagnosis of pediatric and extrapulmonary TB. So we will perform a study on 18 months, a prospective hospital-based study in Bangladesh with 2 cohorts of people with confirmed and unconfirmed TB. And we will evaluate 2 blood-based assays, so the RISC-6 assay and also the Cepheid host response prototype. We expect to improve patient management through the use of this blood-based assay, and also to have a sort of proof of concept that this kind of test could be used in a decentralized manner at the community level. Since 2020, we also worked on latent TB infection, and we are evaluating different strategies to improve latent TB screening and management in Madagascar and Cameroon with our partners from the Institut Pasteur de Madagascar, Antananarivo, and the Centre Pasteur Cameroon. So briefly, in this project, we enroll index TB cases, and also the household contacts are enrolled by community healthcare workers on the field, and also community clinical research assistant. All the household contacts are follow-up over 24 months period with different time points. The high-risk population, such as children under 5 years old and people living with HIV, are proposed a TB preventive treatment according to WHO guidelines. And all the biological samples are sent to the National TB Reference Lab to be analyzed with different diagnostic tools. For active TB cases and household contacts, we are using GeneXpert and TB-RIF, IGRA, smear microscopy, chest X-ray on the IGRA. So we are evaluating quantiferon TB Gold Plus and also the T-spot assay. Tuberculin skin test, and also we use dried blood spot for RISC-6 assay. We also include a COVID-19 serological and virological detection in this project, and MAM will present just after the result of this setting up of serological assay on Luminex platform. Some midterm project indicators. So Madagascar enrolled 858 household contacts, and Cameroon enrolled 316 household contacts. The IGRA positivity rate is quite high, above 50% among the household contacts. And the high-risk population under TB treatment is nearly 43%. It means that 1 person over 2 did not receive the TB preventive treatment. According to WHO consolidated guidelines on TB, these are the recommendation we are follow up in this project. So among the household contacts, the children under 5 years of age and people living with HIV receive the TB preventive treatment. New recommendation suggests that all the household contacts now should receive TB preventive treatment, which raise some concern because there will be a lot of people to treat. So is this new recommendation is feasible in low-income countries and in country with a high TB incidence? Will it not involve treating infected people? And what will be the impact on treatment acceptance? So in this program, we tend to include the IGRA. And we are facing another issue. When you have a negative IGRA among household contact, this individual is considered a non-infected individual and doesn't need TB preventive treatment. But we don't know how to proceed with a positive IGRA within household contacts. Our idea is to go further and to evaluate or to discriminate the people who have recent infection from those who have a remote infection. The individual with a recent infection are more likely to progress towards active TB and are the specific target for the TB preventive treatment. In counterpart, the people with a remote infection have lower risk of reactivation and are not the target of a TB preventive treatment. So far, the IGRA doesn't discriminate between recent and remote infection. And we would like to target people who need TB preventive treatment in this project and to evaluate the cost effectiveness of this approach. So we have submitted a project to analyze the biobank of the APRICID project. We will evaluate the lymphocyte activation by flow cytometry as a biomarker of recent or remote infection. And we will use the PBMCs that have been stored in this project. We will also evaluate proteomic signature by Luminex using plasma and also RISC-6 assay by RT-qPCR using dried blood spots. Recently, we signed a beautiful collaboration framework with the IRD, the Institut de Recherche pour le Développement, and we are very proud of this agreement because we share a lot of objectives with them. We'd like to develop synergy on our personal research program on TB, give access to innovative and efficient TB diagnostics at the community level for effective management of the most vulnerable population. We can build on each other expertise. IRD has a strong expertise on the field with a TB Speak project that will be presented just after my presentation. We also signed a collaboration with the Hospice Civil de Lyon in France, our colleague in the hospital in Lyon. We set up the Lyon TB Study Group, which is a kind of a group to develop translational study of host pathogen interaction for improved diagnosis and management of TB. This group is led by Florence Ader, who is the head of the infectious disease department, and Mona Dumitrescu, the manager of TB diagnosis lab at the New York City Hospital. This group has a strong expertise in molecular epidemiology and basic TB research. And also with our recent findings, we can also add immunology of TB, some research on biomarkers to this group. So the idea is to have a pole of expertise in France to receive students from the Gabriel Network and members of the Gabriel Network to train or to develop research program on TB within this facility. We will still continue to supervise PhD students, so with Florence Ader, the head of this group. And our main perspectives are to deploy and coordinate clinical operational research project on TB, continue to promote access to innovative TB diagnostics, to continue to build TB research capacities, and also to promote knowledge sharing on TB. I would like to thank all of you for your contribution since the last years on this beautiful project, and I hope we can go further together. Thank you.
Thank you, Jonathan, for this beautiful presentation.
Thank you.
I have one question before yours, if possible. In the schema you showed regarding the child TB, so children below 5 exposed to TB. So the WHO guidelines have been recommended in the last years that beside any immunospecific TB test, you should do the preventive therapy with INH. So because the immaturity of the immune system is so important that lead them, especially if they are very young, to develop active TB anyway. So, and the other TST or IGRA can be not sufficiently able to detect an immunospecific response to TB antigens. So for this population, I would go far without any testing to
sure.
preventive therapy, because at the moment, these are the recommendations. So beside that, research is wonderful as always, and
I agree.
whatever
I agree.
it's needed, it will be done.
Yeah, I agree. In the APRECID project, we only have 40% of this high-risk population who received the TB preventive treatment. So
this is a side effect, that a side project that can be done within the Fondation, because I guess you would like to have both an increase in the diagnostic ability from the different centers, and also of the clinical outcome, also in terms of public health issues. So to really do a parallel TB clinical project led by pediatricians in order to support the preventive therapy below 5 years of age would be very important.
Yeah, I
would
agree.
be very important. Please, Luke.
Thank you, Delia, for giving me the floor. Thank you very much, Jonathan, for your presentation, which is very, very clear. I would like you to go back, please, to the slide where there is the algorithm to give the treatment, the preventive treatment, if you can, there, with the here. You said that the person with which we talk here are children under 5 and people living with HIV. You propose to do the ICRA test. If it's positive, then you would like to know, is it a recent infection or remote infection?
Yeah.
How do you know that? Because these are children that are in the household contacts, but you didn't know how, if the children are infected or not. How do you do the differentiation between recent infection and remote infection in those people living with HIV or children under 5 with positive ICRA?
Yeah, thank you for this beautiful question. So the idea is to add another tool to the IGRA. And recently, the team from the South Africa TB Vaccine Initiative described this paper that showing that the lymphocyte activation evaluated by flow cytometry can discriminate the patient with recent or remote infection. So this is an additional test that can be added to the IGRA, knowing that it's quite difficult to set up on the field. But we also have mainly probably point of care test that can be added and have the same information, and we will evaluate it. Thank you.
Yes, please.
Thank you, Jonathan. So about your algorithm again, should it not include as well the results of the drug resistance profiling of the index case to adapt or even decide not to give a preventive treatment?
Yeah.
In other words, if the index case is INH resistant, for instance, INH preventive treatment is useless. So.
Yeah, I agree. This is another recommendation of WHO, is to check the DST as well for the index case, TB cases.
I have one last question. It is the same question that I posed in the previous days. In the system you set up, you have already a whole blood cell system evaluating the HBHA responses, the quantiferon responses, and so on. So, and in parallel, you had a very beautiful slide where you show all the methodologies you are going to use, or you are using actually. And you may add, so you are evaluating also if they are COVID, that one, this one. So you are evaluating if the individuals have been exposed or not to COVID-19. And you do the PCR and the serology assay. You may measure, in addition to that, and the system is very easy as you set up. So the T cell specific responses to SARS-CoV-2. So you need only one additional well with the blood, because you have the mitogen, you have the nil already, with the peptides, with the SARS-CoV-2 specific peptides, and you are going to measure the presence or not of T-cell-specific responses against SARS-CoV-2. So it will be even more complete to test it.
Thank you, Delia.
Thank you very much, Jonathan.
Thank
you. Yeah, I had one small question, but I can give it later. So we can probably move to our next speaker. And before I present the speaker, I also wanted to express my gratitude to the Foundation Marius and the organizers for bringing us to this beautiful venue and for the exceptional hospitality. Thank you so much. So our next speaker will be Marilyn Bonnet. She will be joining us through the video conference. I hope you can connect her now. So Marilyn is an MD and PhD. She's a medical epidemiologist. She's trained in medicine, pulmonology, and has a doctorate in public health from the University of Pierre and Marie Curie. After working for Medicine Sans Frontières and tuberculosis program in Armenia, Georgia, and Russia, she coordinated the TB research activities in Epicenter in Paris, France, between 2003 and 2013. So good morning, Marilyn. Happy to welcome you. Marilyn is a very good friend of my home country, Georgia. Lastly, to mention, she spent 5 years in Uganda coordinating tuberculosis research activities on improvement of pediatric TB diagnosis, shortening TB treatment duration, and improving treatment of co-infected tuberculosis and HIV patients. So Marilyn will be giving us the keynote lecture on the childhood tuberculosis. Floor is yours, Marilyn.
Yes, thank you very much. Good morning, everyone. It's really my great pleasure to be with you today, and I apologize for not being able to be physically present. And I would like really to thank the Fondation Mérieux for inviting me to give this keynote lecture. First of all, I just want to check, do you see my screen and do you hear me well?
Yes, very well. We can hear and see you very well.
Okay, very good. So, so my presentation will present some epidemiological data on childhood tuberculosis, and it will then focus mainly on the missing pediatric TB cases. First, the underdiagnosis of childhood TB, then the poor uptake of TB screening and missed opportunities of screening, and then I will finish by an update on pediatric TB treatment. So regarding the epidemiology of childhood tuberculosis, using the last data from the 2021 WHO TB report, it is estimated that there is almost 10 million TB cases that occurred in 2020. And they estimated that 11% of these cases occurred in children, representing a bit more than 1 million of estimated cases. Then in practice, 5,800,000 TB cases were notified to WHO by National TB Program, and among them only 7% of children, representing a bit more than 400,000 notified. Then if we compare the notified with the estimated numbers, we have a 63% of childhood tuberculosis TB that was not notified to WHO, either due to underdiagnosis or underreporting. Regarding death, there is 1.3 million of TB deaths that occurred in 2020 among HIV negative patients, and 60% of these were children. And then among HIV positive, there were 214,000 TB deaths, and 10% occurred in children. And I will just finish these slides by highlighting, like it was done in the previous presentation, the significant impact of the COVID pandemic with, as you can see on this graph on the right, an increase of deaths, both in HIV negative and HIV positive patients globally in 2020. So if we look at the cascade of care for TB cares, and starting from the estimated numbers of TB in the community, going through the patients seeking cares, being diagnosed, started on TB treatment and cured for TB, and applying the data of pediatric TB. So in the community, there is, according to the WHO, an estimated number of 1.1 million of TB cases. Then only, as I said, almost 400,000 were notified to the binational TB program to the WHO, meaning that majority of them were the diagnosed TB cases. Then still looking at the data from the WHO TB report over the 3 years, 2018 to 2020, there were 1.4 million of children studied on TB treatment, and this represents only 41% of the target for the same period. And then if we look at the MDR TB among children, there was only 12,219 children started on MDR TB treatment over that period, which represented 11% of the target, according to the WHO. Then considering the treatment success based on cohort for 2020 of drug susceptible TB cases, it was 88%, so relatively good treatment outcome globally. Then some groups have trying to establish the true estimates of pediatric TB mortality using mathematical models. And they established that 96% of children who are dying from TB died without having access to TB treatment. And on the left side of the slide, you can see that this is mostly in Asia, Southeast Asia, and in Africa. And then on the right side, you can see with the big orange square that the vast majority of these children were untreated children younger than 5 years old. And majority of them were HIV negative children. So there is a clear gap of detection of childhood tuberculosis due to underdiagnosis. The diagnosis of pediatric TB is relatively complex, especially in a context of inadequate and insensitive tools. First of all, the physiopathology of tuberculosis is still not completely understood. There is clearly a lack of research on childhood tuberculosis. The rule of extrapolating adults' findings to children for recommendation is not always relevant and adapted. And one of the main barriers for the research on diagnosis in pediatric TB is the lack of good reference standard. We cannot really rely on microbiological reference standard only as we used to do for adults. In addition to that, in high TB incidence and resource-limited countries, childhood TB services are very much centralized at high level of healthcare system. So there is a clear problem also of access to pediatric TB cares. Looking at the dynamic spectrum from infection to disease, I think this is quite known now, but we are far from the classical dichotomic infections and disease stage of tuberculosis. In fact, and this is even more true in children, there is a continuum from the infections to the disease, moving from the TB infections to incipient disease and subclinical disease, where you have already a very early stage of disease, but without symptoms. You may have already at that stage some radiographic change, then moving to limited disease and severe disease. So basically the microbiological diagnostic tools that are currently available today will only be able to identify in children the severe disease and some of the limited disease. Looking at the disease spectrum, so these slides present the different clinical manifestations of pediatric TB, and it's highly dependent on the age of the child and also, of course, of the advance of the disease. So, I mean, starting from the uncomplicated lymph node disease, moving to the progressive gun focus, and then airway compression by lymph node, and then moving to the bronchopneumonia, expansive lobar pneumonia, disseminated or miliary disease when there is this lymphatic infiltration, pleural effusions, pericardial effusions, and the adult type pulmonary disease with infiltrate, which is most common in older children and adolescents. So basically the macrobiological tools will only be able probably to detect the lymph node disease with bronchopneumonia, the expansive lobar pneumonia, and the adult type pulmonary disease. So I think it's really important to keep this in mind, looking at the diagnostic test. Then we have also very important challenge in TB confirmation from respiratory samples. Currently, most of the diagnostic tools are based on respiratory samples. And the first challenge is the paucibacillary nature of the disease in children, as I've shown on the previous slides, which will reduce the performance of the test as compared to adults. Then young children, and I would say that younger than 10 years, and for sure younger than 5 years, it's quite difficult to get spontaneous production of sputum. Of course, there are alternative sputum specimen collection methods recommended by WHO, and the most classical ones are the gastric aspirate and induced sputum, and more recently, the nasopharyngeal aspirate and stool very recently. But these methods are poorly implemented globally. Therefore, most of the children are started on TB treatment, do not have bacteriological investigations, and majority of them receive empirical TB treatment. Looking specifically of the diagnostic accuracy of the rapid molecular test for tuberculosis, and from different respiratory samples and stool. And I used only the last cartridge, the Ultra Expert. And these are data from the Cochrane Systematic Review published in 2020 and updated in 21 for the the revision of the pediatric TB guidelines. So from sputum, we have a 73% pooled sensitivity, 64% for gastric aspirate, 46% for NPA, and 53% for stool. But I just want to draw your attention of the very large confidence interval for gastric aspirate, NPA, and stool. And this is because we have few studies, therefore few participants. Specificity is quite good, over 95% for all the methods. Then regarding the two other rapid WHO recommended molecular diagnostic test for the TB lump, there are very few data published in children. Against the macrobiological reference standard, the sensitivity is 84% with a good specificity. And the TrueNat MTB, there are no published data in children. So in terms of recommendations from the WHO, so they recommend initial diagnostic tests for TB in children with preventive pulmonary TB using ultra from sputum, NPA, gastric aspirate, or stool. And in countries with a high pretest probability of 5% or above, they recommend repeating an ultra test if the first result is negative. Then regarding TrueNat and TB lump, the recommendations are extrapolated to children from data in adults. But we should not forget that 25% of children may present extrapulmonary TB. So the recommendation is to use ultra on CSF as initial diagnostic test for TB meningitis, lymph node aspirate or biopsy for lymph node TB disease, and blood for HIV positive children with sign and symptom of disseminated TB. Regarding the detection yield of experts, it depends a lot on the pretest probability of TB, and a systematic review have shown that it was ranging between 5 and 15% across studies in low pretest probability, increasing to 15 to 45% in high pretest probability. And it is known that most of the children seeking cares at tertiary referral hospitals are coming with relatively advanced TB disease after being referred after being evaluated in different health centers before being referred to tertiary hospital, and then they have much higher detection yield than PHC, where they seek cares for the first time. So this is also a big challenge for the PHC level. Although it's not clearly recommended by WHO, several studies have shown that testing a second sample contributes to the detection yield between 6 and 33% of the cumulative yield according to the studies. And it has also been shown that combination of different type of samples can increase the detection yield. And I will just quote here 2 studies. The first one by Olivier Marcy and his team from Panther, where they show that in fact combination of 2 relatively simple specimens, such as nasopharyngeal aspirate and stool, tested with expert, had a 76% sensitivity as compared to 2 gastric aspirate. And in another study where it was among children with presumptive TB, they found similar results of 71%. The study of Panther was only in HIV-infected children with presumptive TB. So there is a poor uptake globally of the microbiological diagnosis, and the reasons are diverse. First one, these respiratory sample collection methods are relatively invasive for gastric aspirate and semi-invasive for nasopharyngeal aspirate and induced sputum. We globally have very few tolerability and safety data with these methods published. We know that there is a risk of bronchospasm and also nosocomial transmission with induced sputum. And globally, there is a poor tolerability of gastric aspirate. There are also a lot of operational challenge. There's a need of fasting at least 2 hours for gastric aspirate, which in most of the settings require hospitalizations. We need specific equipment for induced sputum and nasopharyngeal aspirate, and there is no clear standards. We need some specimen processing methods prior stool testing, and all those things are moving. We still so far need a centrifuge, which may be a barrier. And also for induced sputum, due to the risk of aerosol, we need specific safety measures. Globally, there is also a lack of training, and in particular at low level of healthcare facility, of using these different methods, which results, the combination of this low detection yield and operational challenge may also impact the acceptability by healthcare providers for using these methods, especially at low level of healthcare facility. Then, in addition to the diagnostic test from a respiratory sample, there is this new urine lipoarabinomannan assay, which is the first point of care non-sputum based rapid test. It is based on the detection of lipopolysaccharide of the mycobacterial cell wall. There are currently 2 tests available now, the ALR determined urine LAM antigen test and the more recent Fujifilm Sylvam TB LAM. The diagnostic accuracy of the ALR LAM test against the microbiological reference standard in children with presumptive TB. It's in any children, the sensitivity range according to studies between 28 and 48%. It increased to 43 to 50% in HIV positive children and to 50% in children at increased risk of disseminated TB that included children younger than 2 years, children with HIV infection, or children with severe malnutrition in this study. The specificity was also highly variable, between 60 and 97% across the studies. And we know that there is an issue of bacterial contamination during sample collection, especially in younger children below 2 years. And this might be due to corynebacterial organisms from the skin, which harbor LAM-like lipoglycans. For the Fuji LAM, in inpatients, there was one study showing a relatively low sensitivity as compared to the ALER-LAM with a much higher specificity. But when they look at the accuracy in a specific group, they have a 60% sensitivity in HIV positive children and 62% in malnourished children. In outpatients, the sensitivity was much higher with the Fujilam, 65% versus the ALER-LAM, 31% with a similar specificity. So in terms of WHO recommendations, as for adults, the urine LAM antigen point of care test, and so far it's only the ALER-LAM test, is recommended to assist the diagnosis of active TB in HIV positive children with presumptive TB or advanced HIV disease, or who are seriously ill or irrespective of TB suggestive sign if they have very low CD4 count, below 200 for inpatients or below 100 per millimeter cube for outpatients. And we are expecting this year or maybe early next year recommendation for the Fujilam. So is there still an added value of systematic attempting to confirm TB in children with all this data? So I just quote one of the statements that we made in a recent guidance that we produced with several colleagues who are working on pediatric tuberculosis. So we think that despite challenge, providers should try whenever possible to obtain a microbiological diagnosis of TB in children, as it can simplify the diagnostic pathway, detect rifampicin resistance, allow rapid initiation of appropriate TB treatment, assist the management of complicated case, and build clinicians' confidence in their clinical diagnosis. We know also from studies that children with high bacillary load who are more likely to have a positive laboratory test are at greater risk of severe disease and death, and stand to benefit most from rapid microbiological diagnosis.
Marlene, I need to
Yes.
apologize, but we have very few time left.
Okay, so
yeah.
okay, so I will. So this left us with the clinical diagnosis, and unfortunately, very low attention was given to clinical diagnosis, especially at low level of healthcare facilities, where majority of sick children seek care due to lack of training and low access to good quality chest X-ray and no training of chest X-ray interpretation in children. And also, we don't have a validated score or diagnostic algorithm for children. I just want to show two slides on the TB treatment decision algorithm. The first one is from the PANTHER study among HIV-infected children. This is the first study that really prospectively evaluated a TB treatment decision algorithm and a score for initiating TB treatment. It combined clinical, chest X-ray, history of exposure, and it has a relatively high sensitivity, also a low specificity, but it is quite acknowledged in the pediatric TB community that it's acceptable to over-diagnose some children if we quite be confident that the majority of children with the disease are treated. And then another groups are done a similar study in HIV uninfected children using really the same approach of TB treatment decision algorithm and score. And on the Venn diagram on the right, you can see that the majority of cases, in fact, are started on TB treatment based on clinical of chest X-ray findings. And just very quickly to illustrate from a study in Kenya in tertiary hospital showing that the vast majority, more than 86% of children were started on TB treatment on clinical diagnosis only, and 10% on chest X-ray only, leaving very few starting based on microbiological diagnosis. And then I would like just to move to a screening of child contact, and waiting for children to seek care is not enough. And currently there are recommendations to do active detection in children at high risk of TB. The first group, as discussed before, is the child contact. And it is important to know that there is a 19% risk of TB disease in children below 2 years compared to children above 5 years, where it is 9%. And the recommendation of the WHO is to use symptom screening and chest X-ray for screening of any child contact below 15 years, using cough, fever, poor weight gain, reduced playfulness or lethargy, with a sensitivity of 89%, and still a poor specificity of 69% against a composite reference standard. For chest X-ray, the sensitivity of any abnormality in a systematic review was 84%, with a specificity of 90%. Unfortunately, we still are lacking data in children for the use of the computer aid detection software, the CAD, which is now used in adults. And there is no recommendation of using molecular method for screening in children. The second high-risk group is children living with HIV due to the rapid progression to severe disease and death. So the recommendation is that children with HIV who are less than 10 years should be screened for TB at every encounter with healthcare workers with cough, fever, poor weight gain, and close contact. And in a systematic review, the sensitivity is quite low for screening tests, 61%, with a high specificity. And the data from a retrospective international longitudinal cohort has shown really similar results of accuracy. And there is no data to extrapolate findings from adults on chest X-ray, CRP, or molecular method for screening children with HIV infections. I would also like to insist on the missed opportunities of screening. A systematic review has shown in 2015 that children with pneumonia may have tuberculosis. And in these studies, they reported that 7.5% of children with MTB investigation were culture positive, and that the majority of symptoms has a very short duration. The inpatient case fatality for pneumonia associated with TB in this systematic review range between 4 to 21%. Then in another a diagnostic study, the PERCH multi-country case control study of children with pneumonia, reported similar results with 6% of children with pneumonia with MTB confirmed on respiratory samples. Another study has shown that the population attributable fraction of MTB transmission to children due to household exposure was much lower than what we were thinking, ranging between 10 and 30% and being less than 30% in younger children. So it's probably not enough to only screen household child contacts. Also, very interestingly, and I thank my colleagues from the CAP-TB project, which is a UNITAID project to reduce mortality and morbidity in 10 countries, where they assess the effectiveness of screening at different entry points at facility level. And as you can see on this table, I think in terms of volume of screening, the majority was the OPD and MCH. But then if you look in terms of a proportion of presumptive TB identified among the screen cases, the higher proportion was in IPD, as expected, with severe disease, among HIV-infected children because of the high-risk group, and among household contact. And when we look at the number of children to screen to be able to diagnose one case, the more efficacious, effective approach is probably to screen the household contact as recommended, the HIV-infected, malnourished children, and children from the IPD. But there is no use of doing systematic screening for any child coming to the MCH. And I will finish with the 3 slides on treatment update. And from treatment preventive therapy, I will just quickly highlight the fact that WHO has also endorsed 2 shorter regimens for preventive therapy, the 3 isoniazid rifampicin and the weekly regimens of 3 months combining isoniazid and rifampicin for children older than 2 years. Unfortunately, only 29% of the 5-year sub-target of children receive TPT. And For that reason, WHO is proposing a pragmatic approach of using a simple symptom screening without diagnosis of latent TB infections in these high-risk groups and without chest X-ray, because there is more benefit than risk, even if we over-treat with treatment preventive therapy some of the children who are not in fact infected. They are promoting and the implementation of shorter regimens to improve treatment adherence. And they're also promoting community intervention to overcome the parents' challenge to come to facility, regardless of the reason, transport, stigma. And I will finish on this very important treatment results that has been shown at the Union Conference last year, reporting one of the first randomized phase 3 clinical trial evaluating a shorter regimen of 4 months in children with non-severe TB on using similar first-line drugs at the same dosage. Pulmonary TB, limited pulmonary TB was defined by only 1 lobe or less, no obstruction, no pleural effusion, no miliary, or only peripheral adenopathy, sputum negative. And as you can see, they were able to show the non-inferiority. There was no difference in terms of treatment outcome up to 18 months after a randomization. So I will conclude that the top priority for childhood tuberculosis is still to find the missing case. New tools are needed for screening and diagnosis of TB in children to be able to identify the children at risk of developing TB once infected. We need high sensitive non-sputum based tests, but that requires more investment in biomarker research. We need also to improve access to existing tools for high burden and resource limiting countries. And this will probably need innovative model of care with decentralization, community-based model, more investment in training and mentoring of staff for clinical diagnosis, and improved chest X-ray access and simple interpretation. Thank you very much for your attention.
Thank you so much for this very rich and interesting lecture. And thank you also for making it on time. We can probably take 1 or 2 questions maximum from the audience. Yes, that's clearly a lot to be done to scale up the childhood TB diagnostics. I think there is no questions from the audience. We will thank you once again. Thank you for being with us. And we will move to the next speaker.
Thank you for this beautiful keynote. And for me now it's a pleasure to introduce you Olivier Marcy. His papers have been also mentioned in this presentation. He's a very well-known clinical epidemiologist and researcher at the University of Bordeaux, and he's the research director at IRD, the French Institute for Research and Sustainable Development. He has been done several multi-center studies in Africa and in Asia on pediatric TB, and is one of the coordinating investigators of the UNITAID funded TB SPEED project on child TB diagnosis that has been also already mentioned. Today, he will talk to us about TB SPEED.
Thank you for this kind introduction. Thanks to the Mérieux Foundation, thanks to the organizers for allowing me to present our project on behalf of the whole TB SPEED Consortium. Sorry, I will share my screen. And I want to thank also Marc Bonneville, Jonathan Hoffman, Laurent Raskin, François Xavier, and Stéphane, with whom we've been discussing about this partnership that Jonathan mentioned. Can you see my screen now? Is that okay? I have difficulties to put it in full full screen mode. Maybe
It
it
seems
will
that you
come.
just started,
Okay.
so probably it's coming. Yes, we see it.
Is it? Oh, someone is sharing on my behalf. Or is
We
it?
can
No.
see. You can
Okay, great.
start.
Perfect. Okay, so I'll tell you about TB speed. For some reason, I cannot see my full screen myself. So I'll get back to it. Yeah, so TB Speed is a research project to strengthen pediatric tuberculosis services for enhanced early detection. Marine has already well set the scene globally. As you know, the numbers change from one year to the other in the estimates, but these were the 2020 WHO estimates. But globally, we have 1 million TB cases in children every year, so 10% of the overall TB burden worldwide, and globally, one children out of 2 only is diagnosed, and 1 children out of 4 will die from the disease, and globally because they are not diagnosed. So really, the numbers are striking, and Marilyn explained well what are the reasons and what we need to do to move forward. So in this context, the TB Speed project is aiming and has an ambition to contribute to the reduction in childhood TB mortality by delivering a feasible, cost-effective, and decentralized childhood TB diagnosis approach to enhance case finding and access to treatment, because you understand that really the diagnosis is really the major mortality issue in children. So our research, the TB Speed is a research project. It has been ongoing since October 2017, and as a project, it will end in September 22, so 5 years in 7 countries, 1 country in Southeast Asia, Cambodia, and 6 countries in Sub-Saharan Africa, Cameroon, Côte d'Ivoire, Mozambique, Sierra Leone, Uganda, and Zambia. And as you mentioned, it's funded by UNITAID and the initiative and the INRS. So we have 2 major areas of research in TB Speed, and Marilyn mentioned the challenges, and we are trying to answer those challenges. First, decentralized TB diagnosis at district level, because as you understand, children are not accessing proper childhood TB diagnostic assessments, and also increase detection of TB in children which are especially vulnerable to the disease, and we'll go into that. Here are the TB Speed countries, and you can see the incidence estimates from WHO in 2016 when we started the project in those countries, with countries with high to very high TB incidence. When you're in Mozambique, these are among the highest incidence in the whole world. There are 6 outputs as you take them, or work packages, if you will, in TB Speed. 3 are really clinical outputs, and 3 are technical outputs. As I mentioned, we are trying to build an overall approach. So in the clinical outputs, we are aiming to answer some very important questions around decentralization of TB diagnosis. I'll show you the study design. In output 2, work package 2, we are assessing the impact of detecting systematically TB in children with severe pneumonia. Marilyn mentioned that really TB is common in this group. Then in output 3, or work package 3, we are specifically developing and validating tools for those very severe and vulnerable children with either HIV infection or severe acute malnutrition. And then in the technical outputs, we are trying to develop tools or to address other questions around optimizing specimen collection and processing methods to enable this at very low level of healthcare. We are looking, of course, and you understand why, at the cost effectiveness of the proposed approach, their budget impact also, and how we can make things more less costly for national TB programs. And there's a whole output led by Marilyn on this communicating the results, disseminating discussing with the stakeholders, including WHO and the national TB programs. So I'll take you now through the key studies that I mentioned as in the clinical outputs. In the TB speed decentralization, our objective is to assess the impact on childhood TB detection of decentralizing an innovative childhood TB diagnostic approach, and to compare the efficiency, the feasibility, and the acceptability of two different decentralization strategies. So this is a large operational research with a cross-sectional before and after design and a nested cohort. It will be, it has been conducted because actually its enrollment has just finished in this study in 6 countries from the TB Speed Consortium that you see mentioned here. And we have 2 districts enrolled per country. So the intervention in this study is at 2 levels. At patient level, we are introducing the innovative childhood TB diagnostic approach with systematic screening, a thorough clinical evaluation with clinicians have been trained and are supported in this clinical evaluation. And Marilyn reminded us how important this step is. And in terms of microbiological or molecular diagnosis, we are doing expert ultra on nasopharyngeal aspirates and stool samples. I would say this is the TB Speed really a microbiology strategy. And we are using optimized chest X-ray with digital X-rays and simplified reading tools. And in terms of health system, we have the 2, we are also intervening at the health system level with 2 different decentralization strategy. One that is focused on the district hospital. And as you know, in many countries, district hospitals do not yet have proper childhood TB diagnostic approaches or assessments. So it's really decentralizing at district hospital level. And as you can see, it's rather small on my slide, but there, the expert ultra, the clinical diagnosis, the chest X-ray are positioned at district hospital, and the primary health centers are only doing screening and referring for diagnosis. And in the PHC focus strategy, so PHC for primary health center strategy, expert ultra on NPA, clinical diagnosis and screening are done at the PHC. So really we are bringing the molecular lab to the primary health center lab. As I told you, enrollment just finished in the study. We screen over 150,000 children and for symptoms, and we have up to 3,000 children enrolled in the study. So are in the process of cleaning up the data and hopefully to have results available to the global community soon. Then so this was the part on decentralizing diagnosis. And as you know, as you can see, we don't yet have the results. And then our work, and I told you about the other axis or the other part of our work on vulnerable children. So we identified 3 groups as really highly vulnerable because they have a high risk of TB disease, a high risk of death, and a high risk of underdiagnosis. So triple vulnerability to the issue here at stake. And so we have 3 studies, and I told you already about those studies: TB Speed Pneumonia, SAM, and HIV, targeting children below 5 years hospitalized with WHO-defined severe pneumonia, children below 5 years hospitalized for severe acute malnutrition, and HIV-infected children below the age of 15 with presumptive TB. So let's go through the design of those studies, and I'll be quick on pneumonia because I'll show you the full results of this. And TB Speed Pneumonia is a cluster randomized study. As I told you, we are enrolling children below the age of 5, and we have assessed the impact on mortality. So it's an endpoint-driven study of using expert ultra in all children showing up at hospital level with severe pneumonia. I'll show you more about this. In TB Speed HIV, Marilyn mentioned our work in the Panther study, developing an algorithm, but there is a massive step and sometimes gap between developing an algorithm and validating it in real life settings, not validating it on bootstrapping or on statistical methods, but really taking it to the field and looking at how it works. So here are primary objective will be, really focusing on the sensitivity aspect to evaluate how many children or the proportion of children who are missed by this algorithm. And on the other side, we'll try to evaluate how many children are overdiagnosed by this algorithm in a prospective cohort study with aiming to do an external validation of the algorithm. So it's what is used is the Panther score or Panther algorithm, and I'll show you on the next slide. We have other biomarkers, C-reactive proteins, monocyte to lymphocyte ratios, and we are collecting urine and blood biobanks. We are really interested by, Jonathan, what Jonathan showed us on possible other biomarkers for this group. We'll enroll 550 children in this study, and enrollment will finish by the end of December. So here's briefly the score. It's a simple score, and it's algorithmic transcription, I would say, or how it can be used in a stepwise approach. And basically, every child that scores above 100 can be started on treatment. So you can see here, if a child with presumptive TB has a history of contact with a smear positive case, the points are 118, so it's above 100, he can be started immediately on treatment. If he has fever for more than 2 weeks and hemoptysis in the previous 4 weeks, you see on a clinical ground, you can diagnose TB quickly. In children with severe acute malnutrition, we are not at this stage. We are not at the stage of validating an algorithm. We are at the stage of developing an algorithm. So we are doing somehow a Panther study for children with severe acute malnutrition. So it's a score development diagnostic study. And the tools that we'll use are expert on NPA and stools, chest X-ray, clinical features, abdominal ultrasound, C-reactive protein, the monocyte lymphocyte ratios, plus other biomarkers that possibly will test at a second stage. We are hoping to enroll 720 children in this study, and it will finish enrollment by the end of December this year. So here are the countries with the different studies implemented. Now I'll take you through our first really large results available and that we presented at the TB Science conference that is held in parallel with the Union conference. And really showing you, sharing with you these results that were accepted as a late breaker abstract on the impact of our systematic TB detection using the ULTRA test on nasopharyngeal aspirate and stool samples on mortality. Marilyn already told us about this, the data that's piling up showing that TB is common in children with pneumonia and notably with severe pneumonia. However, as most clinicians, we were trained on thinking that the TB is a chronic disease with long, unremitting symptoms. But we have evidence to show that a lot of these children show up with acute symptoms. And in those cases, diagnosis is just missed because the recommendations and what people have learned push them to only consider TB in case of prolonged symptoms or if antibiotics are failing. So antibiotic treatments are repeated until it's obvious that they fail. But when children are too severe, they will just simply die on the way on this process. So our objective was really to assess whether the impact on 12-week mortality of adding systematic TB detection using ULTRA to the WHO standard of care. I already told you about the design, and so it was a cluster randomized trial with a step wedge design. And you know, the step wedge is when all hospitals start with the control and they are randomly selected to start one by one the intervention. The intervention here being Expert ULTRA performed immediately upon admission on one NPA and one stool. We assessed our primary endpoint was all-cause mortality at 12 weeks, and we assessed the impact using generalized linear mixed effect models that are adapted for this type of studies. So in the control arm, as and actually in the whole study, children accessed the WHO standard of care for severe pneumonia, which includes, as you know, IV antibiotics usually ampicillin plus gentamicin. Oxygen therapy if required, if children are below 90% of saturation. Some supportive care, and of course, for those who are HIV infected or malnourished, access to antiretroviral treatment or therapeutic feeding. The intervention, I already told you about it, but just to show it, is really based on a microbiological sample collection strategy, nasopharyngeal aspirates that are really easy and quick to do, easier than gastric aspirates, and stool samples. And they were tested on ultra using two types of device. The NPA, we were aiming to have a turnaround time to NPA results of 3 hours. So in this case, they were either tested in the central labs or in side labs using this battery operated G1 Edge machine. And all stools that required stool processing before testing were tested in the central lab. And we had TB drugs available in the wards to start treatment immediately. So from March 2020, March 2019 to March 2021, we enrolled children in the study with a 6 months break due to the COVID pandemic. As you can see, so out of the 15 hospitals in the study, we had 2,570 children enrolled. 1,401 were enrolled in the control group, and 1,169 were enrolled in the intervention group. Almost, around 95% receive antibiotics, around 95% access oxygen therapy if they required it. And in terms of the intervention, you see that 99% at ultra perform on at least one sample, and up to almost 80% at ultra perform on 2 samples. All children were included in the analysis. Who were those children? They were young children, 11 months median age. There was no difference between the control and the intervention group in terms of demographics. As you can see here, pneumonias were slightly more severe in the control group with lower peripheral O2 saturation, 92% at inclusion, and higher respiratory rate as compared to the intervention group. And they were more severe acute malnutrition in the intervention group. You see up to 26% in this vulnerable group versus 17% in the control group. The HIV positivity rate was similar. It was 5% in both groups. So at the end of the 12-week follow-up for all children, you can see that 110 children, 7.9%, had died in the control group, and 90 children, 7.7%, had died in the intervention group. So in this unadjusted comparison between groups, and as you can see, there was no difference. So the intervention doesn't seem to impact the mortality. Of note, the withdrawal and loss to follow-up rate was really small in this large study. And you can see on my slide that our protocol hypothesis for mortality were 15% in the control arm and 10.5% in the intervention arm. So looking now at the analysis that is based on the model, so taking into account severe acute malnutrition and pneumonia severity at admission, to account for the difference between the groups, you see that there is no impact, obviously, with a 0.97 adjusted odds ratio and no significant. So there was no impact of the intervention on mortality. I'll be quick on that. And okay, so looking now at what the feasibility of our sampling strategy and ultra testing. In the intervention group only, of course, so you see out of 1,169 children included in the intervention arm, the success rate of NPA was very high, with 97% NPAs that were successfully collected, and you see no SAEs, no severe adverse events, no severe dyspnea were related to NPA in this group. And overall, we were able to obtain 96% of valid ultra results with this strategy. using the stool sample and a sample that is now really, I would say, fashionable, and that a lot of people are interested by this sample, you see that the successful collection rate is not as good as with the NPA, with 81% of children only with a stool sample collected, and overall 79% with the valid ultra results. We'll look into the detailed results of ultra performed in those children. You see that ultra was positive on 21 nasopharyngeal aspirates, on 16 stool samples, for a total of 24 children, 2% of children with positive ultra samples in this group. In addition, 65 children are at TB diagnosed on other grounds, clinical features, chest X-ray, maybe. We are still looking into this. So a total of 89 children in this group were diagnosed with TB. And you see that the ultra testing contributed to 27% in this group. So if we look now at the impact of the intervention on TB diagnosis, looking in both groups, you see we just talked about the 89 children. And in fact, you see that in the other group,
Olivier,
TB was also diagnosed in
Olivier,
yes.
Your time is finished. If you may summarize. What
I'll summarize. This would be my I have only one more slide, I would say. And so you see that TB was diagnosed in 75 children with a significant difference when in the unadjusted analysis, and looking at the model that takes into consideration the fact that there is severe acute malnutrition, there is no more difference between groups. So it seems that severe acute malnutrition itself, which was more frequent in the intervention group, may have been the triggering factor for TB diagnosis. So as a conclusion, at this stage, the study, this very large endpoint-driven study, showed that screening with ultra at the time of admission, in fact, did not lead to reduced mortality in children with severe pneumonia. I did not show you this slide, I had to go quickly, but death occurred very early in the follow-up. And at this stage, even if the treatment is effective in principle, it may be too late to intervene because the children are so severe. However, we showed that the microbiological sample collection and ultra testing strategy was highly feasible, had a rather low yield overall compared to what we were expecting. But the high TB treatment initiation and the microbiological confirmation rate support a more systematic use of this strategy in this vulnerable group. And so I'll finish by acknowledging all children, families, people who contributed to this study. Thanking also Marilyn and Eric Obudeya, my co-chairs and colleagues and friends, and thanking you for your attention. Sorry for being a bit long.
Thank you, Olivier, for this beautiful presentation, very clear and very rich. Is any questions from the audience? Please, Jonathan.
Thank you, Olivier. Thank you very much for this very nice presentation. I would like to know if you plan to have the decision score and algorithm into clinical decision support system to help the physician on site in the primary healthcare structure for the triage of children with presumptive TB or pneumonia. Do you think this approach might be worse? Thanks.
You mean yeah? Thanks, Jonathan, for your question. You mean using the algorithm?
Yeah, on the smartphone or tablet.
Oh yeah, that's what I understood.
Yeah.
Listen, I think definitely we are all interested by this option. As you can see, apart from the TB Speed study, where we are validating and testing and developing an algorithm for those specific groups, we are also involved with a working group at international level that is elaborating algorithms and actually providing advice to the WHO for the handbook. And you're right, I'm pretty sure that using it on smartphone, using this type of algorithm on smartphone is definitely a good move. Using more technology, either for reading the chest X-rays in TB Speed, we are giving the chest X-rays, we are providing the chest X-rays back to clinicians on tablets, so they could possibly be available on these devices, and definitely would help. And we have colleagues also testing IMCI approaches, for diagnosis of diarrhea and pneumonia on tablets or on devices for children. And definitely we would like to include the TB component in this.
There is a question from the people online, if we may call them.
Hello,
Through the system.
do you hear me?
Yes,
Yeah. Can
please.
you open your camera? Yeah.
Sorry
Please.
for that. So hello, so thank you so much, Olivier. This is Nyaina from Madagascar, the Institut Pasteur. Thank you so much for this clear presentation. I have one question regarding your presentation, and I would like to ask if you would have any idea on why is there a low yield and low sensitivity of the current ultra test for when using NPA or stools as alternative samples. In your opinion, is it because of the low detection capacities of these tests, or is it just because of the fact that the bacilli are not just located in these sites? I don't know if you could answer that question. Thank you so much.
Thanks for your question, Naina, and it's a pleasure to see you from Madagascar. And none of us are in the room there in the Alps. Good to see you. Thanks for your question. It's something that we are, of course, thinking a lot about. So first, the meta-analysis that Marilyn presented may be overestimating the TB rates because it is based on some countries with huge incidence, and if it's based in very pyramidal systems where you will have the most severe case on top, you may overestimate the prevalence. So maybe our first numbers were wrong. There is a big study, the PERCH study. It's a case control study of pneumonia etiology in children that was funded by the Bill and Melinda Gates Foundation, published results in 2019, and just published country-wise result on the etiological fraction of pneumonia due to TB, severe pneumonia. Globally, they estimated the etiological fraction to 5.9% of culture-confirmed TB. But in fact, it varies a lot from one country to the other. If you are in Zambia, it was 12%, and then in Thailand, it was high too, but it was lower. So the country mix that we have chosen may have played a role in that. So we have to discuss more about, to look at that. I think we show that it's highly feasible. The yield is a bit lower, but overall the confirmation rate is quite high and is in line with what we may expect, 1 out of 4 or 1 out of 3 confirmed by microbiology. So we still have to discuss about those results and also why we do not find a difference between both groups, the control and the intervention.
Thank you, Olivier. Thank you. I think we have to stop at this point. Thank you so much. But it was really very interesting. Yeah, and interesting also to see that it was feasible in terms of implementation. Thank you, and we will move to our next speaker, and this is my great pleasure to present Philippe Supply, who is the senior scientist at the Institut Pasteur de Lille, France. His main research interest is on the genomics and evolution of Mycobacterium tuberculosis, and he also has developed the 20-fold locus muru VNTR genotyping approach, which we're still using over several decades for now. And he has chaired the steering committee of the project Comprehensive Resistance Prediction for TB, an international consortium, CRIPTIC, led by University of Oxford, and was a member of the task force for the next generation TB drug susceptibility testing of the New Diagnostics Working Group, supported by the Stop TB Partnership. And today, Dr. Philippe will present the PLEX-MIC TB, a new MTB drug resistance prediction essay. Floor is yours.
Thank you. So thank you for the introduction, and thanks to the organizers to give me the opportunity to present our work on the development of new assay for culture-free prediction of MTB drug resistance that we have done at the Institut Pasteur de Lille together with GenoScreen. So TB is the first contributor to the mortality due to antimicrobial resistance globally. In 2019, there were an estimated 460,000 new rifampicin resistant or multi-drug resistant TB cases, but only 38% of them were diagnosed and treated as such. And as per the WHO, we know that the situation is getting worse due to the COVID-19 pandemics. One major cause of this major diagnostic gap is the limitations of the current diagnostic tests. So the phenotypic testing of MTBs is very slow. There have been conventional molecular tests that have been developed that are rapid as they are applicable directly on clinical samples. They are globally deployed and they are endorsed by the WHO, but these tests only interrogate a few common mutations associated with drug resistance in one or few genes for a restricted drug panel. So the diagnostic challenge has been further increased by the new definition of the extensively drug-resistant TB, which is now defined as resistance to any fluoroquinolone plus resistant to bedaquiline and or linezolid on top of rifampicin resistance or MDR TB. So, and this reflects the prioritization of these 3 second-line drugs in the new longer MDR TB treatment regimens. However, bedaquiline or linezolid resistant is not tested by any conventional assay. Now, this is a problem because acquired resistance to bedaquiline or linezolid has been described, and natural resistance to bedaquiline has been identified even in naive clinical strains. So whole genome sequencing represents an attractive potential solution for extensive genotypic testing. So we, with the CRIPTIC consortium, we have evaluated the potential of whole genome sequencing for prediction of drug susceptibility or resistance. And this was done on a total of more than 3,000 genomes of M. tuberculosis complex isolates, of which about 1,000 were sequenced by GenoScreen. So in a first step, a catalog of 120 resistance mutations was identified in a set of 14 candidate genes in a training set of 2,000 genomes. And the use of this catalog on a validation set of 1,500 genomes allowed to detect about 90% of phenotypes with a sensitivity of 92% and a specificity of 98%. And this was superior compared to the conventional molecular assays. And these results were confirmed at the scale of 10,000 genomes for first-line TB drugs, anti-TB drugs, with again sensitivity and specificity well above 90% for these drugs. We then evaluated as well the use of whole genome sequencing prospectively to predict drug resistance. And this was compared, the scheme using whole genome sequencing was compared to the classical diagnostic scheme. And again, the performances were above 90% for prediction of drug susceptibility. And in addition, the use of whole genome sequencing was faster than classical diagnostics and even cheaper than classical diagnostics. However, for whole genome sequencing, in most of the cases, you still need a primary culture, which takes at least 1 to 2 weeks, which then delays diagnostics. So together with GenoScreen, we exploited the concentration of the drug resistance determinants in the set of candidate genes to develop a targeted next generation sequencing approach. So in this approach, instead of performing whole genome sequencing, we amplify to 18 main drug resistant targets in 21 amplicons, including as well a target for Mycobacterial species identification and a target for M. tuberculosis complex genotyping. And this is done by using a dedicated kit, which is called Dplex MIC-TB. So after this amplification can be done directly on a clinical sample. And this is followed by library preparation and sequencing and analysis of the sequencing data. The turnaround time takes from 24 hours to 2 days, depending on the sequencing platform that is used. So because we perform targeted sequencing instead of whole genome sequencing, we have a more flexible throughput, which can go up to 384 tests in a single sequencing run. And because we do targeted sequencing, we can go deeper to detect heteroresistance. This can be performed on ethanol or heat inactivated samples. And this can be done by using these ready-to-use Dplex MIC-TB amplification kits, which comprises access to a dedicated web app for the analysis of the sequencing data. So these are the targets that are included in the assay. So we have a total of 18 different main gene targets associated with anti-TB drug resistance. And we can predict resistance to 13 drug classes in total. So this comprises the first line drugs and most of the second line drugs, including as well bedaquiline, clofazimine, and linezolid. For species identification, we use a housekeeping gene, HHP65, and based on this, we can predict more than 100 different mycobacterial species, identify them. And for genotyping of M. tuberculosis complex isolates, we combine spoligotyping with SNPs that can be detected in any of the other gene targets. So the analysis of the sequencing data is done by using a fully automated calibrated analysis pipeline, which comprises 3 compartments with integrated databases, one for species identification, one for genotyping, which comprises, for instance, the CIPVIT web database for spoligotyping, which is quite extensive. And for drug resistance prediction, we use different mutation catalogs, including now the mutation catalog that has been recently published by the WHO. So the analysis of the sequencing data is done by using the Dplex MIC-TB web app, which includes a number of multiple interactive tools for interpretation of the data, including, for instance, the resistotypes here. And this is a result obtained for one XDR sample, which is visualized here. And on this map, you have the different gene targets and the different drugs. And the automated analysis pipeline detects mutations in the different targets. In red, you have the mutations that are known to be associated with drug resistance. And in other colors, these are the mutations that are known not to be associated with drug resistance. So, and based on that, you can obtain the resistotypes for the different drugs. In red, prediction of resistance, and in green, prediction of susceptibility. So, and in this case here, you have the detailed list of mutations that were detected. And in a specific case for the RV0678 target, which is associated with resistance to bedaquiline and clofazimine, we have a special case where we have only a minority of the sequencing reads which carry the mutation associated with resistance to these drugs. So, and these minority populations can be detected thanks to the large sequencing depths that can be achieved. So in this case, we have a sequencing depth that is above 1,000. And this allows us to detect minority variants down to 1 to 3%, which is close to the range detected by phenotypic testing for defining drug resistance under treatment. So, and this is much better than the conventional molecular assays that don't go below, at the very best, below 5 to 10% of minority variants detected. So we have extensively evaluated the performances of our assay that was recently published this year in ERG. So we have evaluated the performances based on data from more than 4,000 isolates and from 1,600 sputum specimens. This was done versus phenotypic DST and versus whole genome sequencing. As an example of result, this slide shows you the distribution of the main resistant determinants that were identified in the set of more than 3,000 genomes that I showed before for the different drugs. And for comparison, these show the mutations that are detected by GeneXpert MTBRIF only in RPOB and in one region of RPOB. These are the mutations that are detected by line probe assays. And these are the mutations that are detected by DiplexMIC-TB. Most of these mutations are captured by our assay. And in this data set, this allowed us to detect or to predict between 97 and 99% of the resistant phenotypes that were predicted by whole genome sequencing. So regarding the comparison with phenotypic testing, we obtained an overall sensitivity of 95% and a specificity of 97%. And we determined a limit of detection for our assay between 100 and 1,000 extracted MTBC genomes. So meaning that it is highly effective, at least on smear positive samples and part of the smear negative samples, depending, of course, on the bacterial load. So importantly, DiplexMIC-TB has been recently shown to be applicable as well on stool specimen. And as we have seen, this is an important alternative diagnostic substrate, especially for children. So in this recently published study, DiplexMIC-TB was applied culture-free directly on stool specimen in two prospective cohorts, one in Eswatini and one in Germany. So after initial detection of MTB by a specific qPCR assay, resistant reports based on diplex results could be produced between 50% and 75% of the samples that were positive for MTB by qPCR. And there was a high degree of concordance with phenotypic DST results that was done on sputum samples in the two cohorts with kappa scores above 80, 0.8 in both cases. So we used our assay in different studies, and this is one example that we published in Lancet Infectious Diseases in 2018. So in that study, we analyzed a set of samples from 4 South African provinces that were initially identified by the diagnostic algorithm in place as monoresistant for isoniazid. So in 15% of the samples, we detected the presence of the RPOB I491F mutation, which is missed by the WHO endorsed tests that are globally deployed. And this is shown in red here. So, and on top of that, we detect additional resistance to all first-line drugs. And this was unsurprisingly and unfortunately associated with an unfavorable outcome for the patients. And in addition to that, most of the samples showed a same oligotype and a same SNP type pattern, so indicating a possible epidemic clone. And this was confirmed by whole genome sequencing data that we performed subsequently. Yes. So, and this analysis showed that this epidemic clone acquired resistance to all first-line drugs before spreading in the different places afterwards. So, and moreover, and worryingly, So we detected as well in multiple samples mutations in the target that is associated with resistance to bedaquiline. So that was such mutations were detected multiple times. Different mutations were detected, and when we mapped this mutation on our whole genome phylogeny, we could see that they were probably acquired after the introduction of bedaquiline treatment in South Africa, indicating that these mutations were selected due to the use of bedaquiline in these patients, which were, however, initially diagnosed as monoresistant to isoniazid only. So this is a concern, of course, for the new oral MDR-TB regimens. So we also exploited our tool as a biological discovery tool. So we had a chance in the frame of a clinical trial that is ongoing in Africa, which is called DIAMA, to analyze the strains from TB patients from Rwanda. And this is the result obtained from one of these samples. And you can see you have multiple blocks of the gene targets that are in blue in this case. And this indicates the presence of multiple SNPs that are unknown. And on top of that, the spoligeptide that was identified was completely unknown to the worldwide database that is quite extensive. So we then performed whole genome sequencing and constructed a phylogeny. And we could show that, in fact, this strain represented a new sister clade, a new ancestral clade compared to the rest of the M. tuberculosis complex. And this supports an East African origin for the pathogen. So my final slide is to give you an idea of where we are for the moment. So the test is now used in more than 25 countries on the 5 continents. So the WHO is using our test as a standalone test in multiple places for surveillance of drug-resistant TB. So we have ongoing clinical trials in Africa and elsewhere, and one will include Georgia as well very soon in the frame of the second TREAT project led by FIND and funded by UNITED. And the test is now marked CIVD since 2019. So, and finally, we have developed as well a prototype test for Mycobacterium leper, which is a very difficult organism as well because it cannot be cultured. So we have developed an assay which is called Dplex MIC-TB, which can be applied directly on biopsies for prediction of drug resistance for anti-leprosy drugs and genotyping. So again, directly on clinical specimens. And we have an ongoing clinical trial, which is called PEOPLE, which is ongoing in Madagascar and in the Comoros Islands. I would just like to finish by acknowledging all the people that have been involved in this work, especially my team at the Center for Infection and Immunity of Lille at the Institut Pasteur de Lille, the R&D team at GenoScreen, who has developed this assay, and multiple collaborators in Belgium, in Congo, in the UK, in Germany, and in Italy. And thank you for your attention.
Thank you so much. Very impressive work. Questions from the audience? Yes.
Thank you very much for your nice presentation. The test that you have developed can be implemented as a point of care test by using, for example, nanopore technology, or is not possible?
I wouldn't call the Oxford nanopore technology as a point of care test, but you still need capacity for molecular biology. We use it as well. So, but still, yes, it can be used on the nanopore platform, but with performance that are lower compared to Illumina sequencing, especially for the detection of heteroresistance, because of the lower accuracy of the sequencing, and therefore you cannot go down below 50% for detecting heteroresistance, for instance. But yes, you can use nanopore sequencing as well.
Thank you so much. And there is one question. If you can unmute, yes, if you can unmute your microphone, please, and come on the camera to give the question.
You hear me?
Yes.
Hello, thank you so much, Philippe. This is Nyaina again from Madagascar, and I know that we are together in this cryptic consortium, but my question is about what you presented today. You said that there are some reef resistance that were not detected with conventional tests that were detected with this duplex method. So does these conventional tests include the DST, the phenotypic DST?
Yes, this mutation can
Wow.
quite often be missed as well by phenotypic DST, and this might be related to the fitness cost of this resistance mutation. So it could be a cause for that. So in those cases, phenotypic testing miss frequently this mutation as well.
Okay. Oh,
yeah.
Great.
But this has been probably adjusted because there has been a recent revision for the critical concentration of rifampicin. This has been decreased for phenotypic testing, and therefore this mutation could be more efficiently now identified by phenotypic testing as well.
Okay, thank you so much.
Thank you so much. There is one more question and probably we will stop there. Yes, please.
Just thank you very much, Philippe, for your talk. Just one question. You mentioned MTB complex, LEPRI, and what about NTM?
So as I mentioned, in fact, our diplex-MYC TB can, and this is true as well for diplex-MYC LEP, we can identify more than 100 mycobacterial species. For prediction of drug resistance for those mycobacteria, this is more complicated because we know much less about the drug resistance mechanisms that are in place. This can be done for macrolides and aminoglycosides. And so we are now developing specific tests for detecting this at least.
Thank you so much. Thank you, Philippe. And with this, we will close the first part of tuberculosis session. And Florence, please let us know when do we come from the coffee break.
As we are very late, we will have a very short break of 10 minutes only because we have online a presentation at the end of the next session. So we have to be on time for them. Especially because they are from USA and they wake up very early for us. So we have to be online on time.
Good morning again. Can you listen to me? Yes.
Yes, it works.
So welcome back from the brief coffee break. And for me, it's a pleasure to meet Mame Diarra Bousso Ndiaye from Madagascar. And she will present in 10 minutes, so strictly 10 minutes, the Apres-Sh study. Thank you so much.
Hi, everyone. Thank you for this introduction, and thank you to the Gabriel Network for this opportunity to present today a part of my thesis work. So I'll try to be brief. WHO estimates that 9.9 million of people are affected by TB in 2020, and 1.5 million of deaths during the last year. And 25% of the world's population lives with a latent TB infection, which is the asymptomatic form of the disease. In Madagascar, 238 person fell per 100,000 person had TB in 2020. So first, the transmission of Mycobacterium tuberculosis is done by aerosol, and in either the infection is cleared by the immune system, either when we have an infection, it can be a latent tuberculosis infection in 90% of the cases, or in 10% of the cases, it can be an active tuberculosis infection. And for the latent tuberculosis infection, 5 to 10% of this proportion of the population will develop an active tuberculosis infection during their lifetime. So the Fondation Mérieux, with his partners, the Centre Pasteur of Cameroon and Institut Pasteur of Madagascar, launched this project called APRECIT, which aim to evaluate strategies to improve the screening and management of latent tuberculosis infection in Cameroon and in Madagascar. So basically, index TB cases are identified, and then we go to their houses and we identify the household contacts. Then they will be followed up during 2 years, and the high-risk population, according to the guidelines of WHO, will be identified and put under the preventive TB treatment. But when we were launching this project, actually we started the enrollment in December 2020. So it was during the first wave of the outbreak of COVID-19. So we added this COVID top-up to the project, which aimed to measure the impact of COVID-19 in the specific population of TB patients and their household contacts. This is the workflow of the study. We collect sputum smear and nasopharyngeal swab from the active TB patients to do the TB diagnosis and SARS-CoV-2 diagnosis. And then for the household contact, we follow them during over 2 years, and there is different point of visit. And at each time of visit, we collect the blood samples. And then with this specimen, we will do some interferon gamma release assay, which allow us to identify the status of the patient, if it's latent or not. And then we wanted to also to identify some biomarkers for the progression of latent tuberculosis infection into the active form of the disease. And we also want to detect the seroprevalence of antibodies or SARS-CoV-2 antibodies in this specific population of TB patients. And to do so, we wanted to develop our own assay, in-house assay. So from here, I will tell you about the development of an evaluation of a multiplex assay for the detection of SARS-CoV-2, IgG, and IgM antibodies in Madagascar. So the first step of this development was to select the targets. So here you have the structure of the virus. This is, you have the S protein, so the spike protein, and the N protein, the nucleocapsid protein. In the spike protein, we have two subdomains, the S1 and S2. And in the S1 subunit, in the S1 subunit, there is the RBD, so the receptor binding domain, which links to the ACE pattern of the ACE2 pattern of the cells and allows the entry of the virus in the cells. So we choose those antigens because those are the most immunogenic antigens of the SARS-CoV-2. And to do so, we use the Luminex platform. So for those who don't know the Luminex, Luminex is like an ELISA, but on beads, which allow us to multiplex and to identify multiple targets at the same time. So here we have magnetic beads. So those magnetic beads have a really specific fluorescence, which allow to identify each of them. So we choose 4 different magnetic beads, and in each of them we coupled antigens. So in the first one, we coupled the S1, then the S2, the RBD, and NP. And when we put the serum of the patient infected with SARS-CoV-2, those antibodies will link specifically to the antigens, and then we will detect the signal with secondary antibodies. So here we have the MagPix instrument, which allow us to quantify the amount of antibodies specifically in the sample. So the first step of this evaluation was to validate the assay. So to validate the assay, we have some parameters that we need to determine. Has the limit of quantifications, the coefficient of variation intra-assay and inter-assay, which are respectively the repeatability and the reproducibility of the test. And those values should be under, under 10%. So here we can see that these values are under this limit. So we can say that this test is reproducible and repeatable. Then we test the performance of the assay. To do so, we choose some sera of patients with SARS-CoV-2 confirmed diagnosis and some negative patients that have been collected in 2015, which was sure that there were no circulating SARS-CoV-2. And we did some ROC curves, which allow us to have the sensitivity and specificity of the test for each target in IgM and IgG. So here we can see that the sensitivity of the test for IgM is between 56% and 84%, and the specificity between 95% and 97%. For the IgGs, we have a sensitivity between 97% and 100%, and the specificity between 95% and 100%, which is really good. So we did this this assay, and then we developed this assay, and then we wanted to evaluate it before to apply it to the TB cohort that we have in the APRECITE project. To do so, we needed to use a well-defined and characterized cohort called the FFX cohort. So the FFX cohort is the first few cases of COVID-19 in Madagascar. It's a WHO protocol. So here it's a patient with a PCR positive at day 1, and then we follow them during 1 year with different time point of visit. Those patients were recruited between March and July 2020. And here we have a median age of 43. We had more symptomatic than asymptomatic patients. Those patients were hospitalized patients. And for the comorbidities, the most represented are diabetes and cardiovascular disease. So we use the test in this cohort, and here you have the seroprevalence of IgG and IgM in this cohort over 1 year. You have here the IgM, the IgGs, S1, S2, RBD, NP. So we are looking at the 5 targets. And for the S1 IgM, for instance, at day 1 we had 80% of seroprevalence, and this rate decreased over the follow-up, so over the year, to reach 40% after 1 year after the infection. For S2, we are at 40% at day 1, and then decreasing till to reach 30% at day 1. We have the same trend for RBD, but for NP, we have a rate between 30% and 40%. Looking at the IgGs here, we have at day 1 for S1 a seroprevalence rate over 60%, and then we are over 90% after 1 year, and we have the same trend for S2 and RBD, which is really interesting because in our cohort of TB patients, we will follow them during 2 years, and this show that the test that we have been developing can help us identify or quantify the amount of antibodies after 1 year of follow-up.
Your time is finished. If you can summarize.
Okay. A bit complicated, but we go further in the analysis. We wanted to know if we can use those values to visualize the cluster, so the group of infection. So here we did a PCA analysis, so principal component analysis, and we can see that we have 5 groups of negative, the positive at 21 days, the positive at 3 months, 6 months, and 1 year. And here we can see that the earlier is the infection, the most we are on the right side of the graph. And older is the infection, the most we are to the negative. We are closer to a negative group. For the clinical presentation, we have three clusters also, the negative, the symptomatic, and the asymptomatic one. We wanted to go further and look at if we can just if we can test those samples, say, okay, this patient have a positive antibodies to SARS-CoV-2, then can we predict, can we say that this person have an infection older than 3 months or 6 months or 1 year old? So
only to say, I was mistaken. You have 9 minutes more. So sorry, apologies.
So I'm gonna wrap up. So we use the test in the APROCID cohort. So this will be my last slide. Sorry. We are between, okay. We use the test in the APROCID cohort. So here we have the seroprevalence in IgG antibody SARS-CoV-2 in the patients that have been enrolled between December and April 2021. So it was during the first wave of COVID-19 in Madagascar. And we can see that for the index and the contact cases, we are about 45% of seroprevalence in a TB cohort, which is, I think, quite high. But we still don't know if those patients at which time those patients catch the virus, and so we need to work on the prediction and the model that we are using to be able to do so. So to conclude my presentation, we showed that we have a robust and reproducible technology for the SARS-CoV-2 serodiagnostic, with a good sensitivity and a good specificity. For the estimation of time since infection and symptomatic presentation, we need to improve the model that we got here, maybe using a larger sample size or defining better the groups. And this tool have been implemented in, developed in Madagascar, so we need to implement it in Cameroon as well, and then apply it to a TB household cohort in the APROCID project. So to finish, I want to thank the Gabriel Network, the Fondation Marieux, my supervisor at the Mycobacteria unit in Institut Pasteur, Dr. Nyain, Dr. Jonathan, Laurent Raskin, and Dr. Mathieu Chenaz, which is the head of the immunology of infectious disease at Institut Pasteur of Madagascar, who allow us to have access to his platform, Luminex platform. And I want to thank also the staff from Centre Pasteur of Cameroon, Sarah Yongo, Verlet, Jules, Valérie. Thank you for your attention.
Thank you for the beautiful presentation, and apologies to have you given cash. I was very interested in your results. Can you go back to the serology data? The previous one? The previous? This one.
Okay.
So these are the results among the contact of TB patients.
No.
Or among the COVID patients?
On the COVID patients.
Among the COVID patients. And day one for you is when they started to come or when they had symptoms?
Day one for us is the day when we had the PCR positive. So the confirmation of their infection.
And do you know if there is a questionnaire that they did fill where you know the exact day of symptoms?
Yes, but actually those we didn't want to use the information in the questionnaire because I told you that all these patients have been hospitalized because the strategy at the beginning of the pandemic. With this strategy, all the patients were hospitalized, and then we are not sure which one is symptomatic or really asymptomatic. And that's why we wanted to use the day when we have the confirmation of the COVID testing positive.
I am asking it because serology tests become positive after 10 days
Yes.
from the start.
That's why, yes, I should precise that here we look at the
No, but
day one.
it's fine. It's only to give a context to the results. Okay. Please.
Yeah, thank you very much for your presentation. It was very interesting. And if I look to this result on this table now, we can see that it is S2 and RBD that are the most important IgM and IgG to see if we would like to have the duration of the infection. Because, for example, for the S2, if the amount is less than 40%, we can see that we are at 90 days after the infection. It is the same for RDB. If it is less than 20%, then we are more than 180 days after the infection. So that is the point of conclusion that we can take from this. And of course, for the IgG, it is normal because it will stay longer. But for the IgM, I think that it is there are only two sites which are very interesting. It is they are S2 and RBD. Is that your conclusion? What is your what did you take from this these results for the explanation of the duration of the infection? Thank you.
Thank you for your question. Actually, this this tool that we've been developing, the main important part of this tool is that we are looking at different signals, okay? And we didn't want to just choose one or two targets. So we went with all the variable that we got. So we have here eight variables, and that's why I presented you, but really quickly, the PCA that we've done using all those variables, because we think that it's not just looking at one or two results, but just compute all of them, and then look at the prediction that we can have for the time since infection. But we are still working on it. Maybe we should do more groups, maybe, and try to use some signature, maybe, of different IgGs or IgM targets.
Please, Philippe.
Thank you very much for the presentation. Is it known whether the Delta variant was predominant over the study period? And then did you look whether the virus genotype could impact on your results possibly?
No, in Madagascar, we don't have yet the Delta variant, but we have the Beta variants that have been circulating during the second wave. And we use this platform Luminex to identify the infection that we got caused by the Beta variant and not the ancestral virus, but using serological tests, because in Madagascar we are not sequencing a lot of samples. We have limited say capacities. Yes, thank you. So we did this work, and the results are published in the Lancet next month. So we showed that there were circulation of the Beta variant before the government did a communication about the circulation of the virus, which had been communicated by the virology unit by sequencing. But yes, we don't have the Delta variant for now, only the Beta.
Thank you very much. Thank you for the nice presentation and good discussion. I think we need to move now for our next presenters. So there will be a series of presentations which will come from the project supported by the Gabriel Network. This is phenotypic and genotypic characterization of isoniazid-resistant strains of Mycobacterium tuberculosis from clinical isolates. And this study has been done in Bangladesh, Cameroon, and Lebanon. And if I'm correct, Cameroon will start. Valerie Duncan. Yes, floor is yours. And for the questions, we will take questions only after all three presentations are presented from the project.
Okay. Good morning again, everybody. As already specified, I'm going to present to you a project. I'm Valerie Duncan from Microbacteriological Unit at Saint Pasteur du Cameroon. And the Microbacteriology Unit is also the National Tuberculosis Referral Laboratory in Cameroon. So the study that I'm going to present to you now is conducted in Cameroon, Lebanon, and Bangladesh. I'm going to present the background, the objective of the project, as well as the study design and the work progress that we perform in Cameroon until now. And my collaborator from Bangladesh and Lebanon will present after me their work progress too in their different settings. So as we all know, tuberculosis remains one of the most challenging global health problem, as resistance to first-line antimicrobacterial drug continues to rise in many countries worldwide. So we have here the global statistic in Cameroon and in the global statistic in the world and in Cameroon in 2020. So the good news is that tuberculosis is a treatable disease, but poor treatment of tuberculosis can lead to multi-drug resistant tuberculosis, which is tuberculosis resistant to at least isoniazid and rifampicin. And we have here the case that we had in the world in 2020 and also in Cameroon. So I want to highlight it here the fact that isoniazid, where we are going to focus in this project, it's one of the cornerstones of anti-tuberculosis treatment, as it exhibits mycobactericidal activity by inhibiting mycolic acid biosynthesis. So isoniazid resistance commonly occurs due to mutation in the CATG genes or in the ENH regulatory region. So successful diagnosis of multi-drug resistant tuberculosis can be done or can be performed through culture-based phenotypic GST. And the limitation of this method is it is time-consuming, and cost-effective. And another method is the molecular genotypic GST through the genotype MDR drug assay. And this method detects resistance through the mutation at CATG and ENH gene for ENH resistance. But the genotype MGBGR+ as is unable to detect resistant profile when mutation occur outside the target genes. We also have next generation sequencing. We talked about it this morning, and the limitation is that it is expensive and it's not available in most of our laboratory. So the problem is that 20 to 30% of isoniazid resistant Mycobacterium tuberculosis lack mutation at the known genes, CATG and ENH. So our research question was, do there exist alternative biomarkers associated with isoniazid resistant strain of Mycobacterium tuberculosis complex from clinical isolate in Cameroon, Bangladesh, and Lebanon? Therefore, our research hypothesis was reduced expression of drug activating enzyme, CATG, and overexpression of efflux pump are other mechanisms through which isoniazid confer resistance. So our main objective was to determine if the reduction in the expression of catalase peroxidase activity and enhancement in the expression of efflux pump influence the mechanism through which Mycobacterium tuberculosis clinical isolate develop resistance against isoniazid. So this project has three specific objectives. The first one is to determine the prevalence of Mycobacterium tuberculosis isolate by culture-based phenotypic test, but that lack mutation detected by molecular assay. The second objective is to determine if isoniazid-resistant Mycobacterium tuberculosis isolate that lack mutation in no genes associated with isoniazid resistance significantly reduce the expression of CAG. And the last objective is to determine if the expression of efflux pump, including the multi-drug resistant efflux pump, differ in ENH resistant and susceptible Mycobacterium tuberculosis isolate. So the result of this study could help in the development of an assay that can rapidly diagnose all isoniazid resistant cases and as such reduce the spread of multi-drug resistant tuberculosis, enhancing effective TB management. So as a study design, a total of 850 archive isolate for all the three countries, Cameroon, Lebanon, and Bangladesh, are going to be identified and isolate, and then they are going to be replicated using liquid culture with the MG BACTEC system. So after the subculture, all the isolates are going to be submitted to phenotypic and genotypic GST using the BACTEC and the genotype MTBGR plus assay. So the isolates that are going to be resistant using liquid culture GST, phenotypic GST, and susceptible using molecular tests are going to be our isolate of interest. So those isolates of interest are going to be submitted to the minimally limited concentration. Then we will perform the whole genome sequencing. This will constitute the M1 of the study. For the M2, we are going to do protein extraction from those isolates of interest and the quantification of protein level of CAG by Western blot. And for the M3, we will perform RNA extraction and the quantification of the mRNA expression level by RT-qPCR. So what have we done so far in Cameroon concerning this project? So the project started in April 2021 after we signed our agreement with the Gabriel Network and received our first installment. So we identify and isolate in our biobank the ENH resistance strain from 2015 to 2020. We identified an other reagent for the M1. These are reagents for the BACTEC, for the culture, the subculture, and the GST, phenotypic GST, and the reagent for the molecular test, genotype MDPDR+. After that, we performed the subculture. We did the phenotypic and genotypic GST was carried out, as well as minimal inhibitor concentration for some strains. We elaborate the SOP for protein and RNA extraction and quantification assay, and also we evaluate the whole genome sequencing cost. So as a preliminary result that we obtained so far, we identify in Cameroon 500 archives ENH drug-resistant MTB isolate. So those strains has been replicated subculture, and after the subculture, we had 41 negative tube. They have been subculture, and the subculture is ongoing. We have positive tube for 424 samples isolate, and 35 were contaminated, though they have been decontaminated, and the subculture is ongoing. So for we performed genotype MTBDR+ on the 424 isolate, And from there, now we have 52 ENH sensitive MTB isolate. So from this isolate, we already performed DST to confirm their resistance on 18 strains, to confirm their resistance. And we also performed the MIC of 5 isolate at concentration of 0.1, 0.2, 0.4, and 0.8. And all those strains were resistant at this concentration. So we can conclude for this preliminary result that actually in Cameroon, we can have about 12% of ENH resistant MTB isolate with lack mutation at the known gene CATG and ENH. So we went through a challenge to be able to start with this project. Okay, thank you. So the most challenge that we had was to perform laboratory tests while waiting for the delivery of reagent, because there was a long delay between the order and the delivery. So we have to use reagent that we already have in the lab for other purposes. We also have to supply Lebanon with reagent for culture and GST, because as you know, he presented yesterday that they have a lot of crisis, financial crisis in the country. Okay. So for the M2 and M3, we are now challenging to set up the protocol using available reagent in the institution. So the difficulty that we had so far was the delay between the order and delivery, as I said already. We also have a difficulty to secure funds for the whole genome sequencing. And I'm thinking that for now we have the solution with supply, with Mr. Philip supply. And we also have to find a company to transport viable strain from Lebanon and Bangladesh to Cameroon, because the M2 and the M3 of the project are going to be conducted in Cameroon, and we need to receive strain for the 2 countries. Also to complete the whole study in the fund allocated, and to complete the study within the allocated time. So our perspective is to sign an agreement with an amendment, with Gabriel Network to extend the study period, to review our budget in order to secure funds for sequencing, and to follow a training for Mycobacterium tuberculosis sequencing and result interpretation. I cannot end without thanking all my collaborators of the ECDDR at Bangladesh, the University of Lebanon, Fondation Mérieux through the Gabriel Network, Centre Pasteur du Cameroun, and particularly my boss, Dr. Sarah Yango. Thank you.
Thank you very much. We don't take questions at this point, and I would ask Mohammed Hajam Mafej, I hope I pronounced it correctly, to continue with the same project presentation from the country experience.
So. No, go. Yeah, but it's not working. Good morning. I'd like to thank the audience for your future patience. And I'm very happy to be a part of this collaborative study under the Gabriel Network. So Dr. Valerie already mentioned about the objectives and study flowchart and some backgrounds, challenges. So I'll not discuss about these things. So I will talk about the updates from Bangladesh. So maybe I'll be very short. So you already mentioned that the TB is one of the leading cause of death worldwide. According to Global TB Report 2020, around 9.9 million new cases and 1.3 million deaths. And more than 8% of TB infected with HIV. And of course, the MDR TB is one of the threat to eliminate TB worldwide, and it occurs 0.5 million and 182,000 deaths each year. So Bangladesh is one of the TB burden country. It ranks 7th among the high TB burden country, and approximately 360,000 new cases per year. And MDR is also one of the biggest problem in Bangladesh. And now it's day by day increasing. So around 3,300 MDR TB cases per year. And the rate of MDR TB cases is very low among the new cases. It is around 0.7%, but it is little bit higher among the retreatment cases, around 11%. This is this data from our one drug resistance surveillance that is held in 2011 to 2015. So around 38,000 deaths each year. And the country has started DOS strategy since 1993. And from 2007, the country has 100% DOS coverage. So I'll skip the background diagnostics that we are used in our study, knowledge gap, objectives. So these are the study flowchart. So in our study, Dr. Valley already mentioned that the 3 countries will perform 850 isoniazide isolates that are resistant and some are sensitive. So according to our agreement, we will perform 150 isoniazide resistance and 6 isoniazide sensitive archived isolates in Bangladesh. So we will subculture from the archived for all of the archived isolates in liquid media, and we will perform the phenotypic drug susceptibility testing using the liquid media, that is MGIT, and as well as we will perform the molecular diagnostic for drug susceptibility testing, that is genotype MTBDR plus, also called the line probe assay, that detect the rifampicin and isoniazide. So end of our experiments, we hope we will find our target groups that are resistant in phenotypic drug susceptibility testing, but sensitive in molecular drug susceptibility testing. And we hope we will perform the whole genome sequencing as well as gene expression profile of CAT-G, gene expression profile of efflux pumps, and protein expression of CAT-G gene. So we collect the archived isolates from our MDR and XDR TB surveillance that is held in 2011 to 2015. We collected the sputum samples from 23 health facilities that covers all over the country. This is the first drug resistance surveillance in Bangladesh. So at ICDDRB, we will subculture the archived isolates and we will perform the DST in phenotypically and genotypically, and all of the desired isolate that are resistant in phenotypic DST but sensitive in molecular DST, we will ship the samples to Cameroon for further experiments like whole genome sequencing or protein expression or gene expression. So updates from our ICDDRB, we have received the Institutional Review Board approval for conducting the research. We signed the financial agreement between the Foundation Meru and ICDDRB. We have completed the staff recruitment and training. We also initiated the procurement process, but it is delayed due to the COVID-19. And finally, we have started the laboratory activities. So far, we have subculture 27 isolates in liquid culture, and among them, we found 20 are positive, and we did drug susceptibility testing among the 20, only 12. And molecular DST is done for all 20 samples. So among the 12 samples that are done in phenotypical DST, we found results for 6 isolates so far. So among the 6 isolates, we found 5 are ionase resistant and 1 is ionase sensitive. And among these 6 isolates, we found all are sensitive in phenotypic drug susceptibility testing. So our desired isolates number is so far 5. That is phenotypically resistant but genotypically sensitive. So I hope we'll complete the remaining subculture and drug susceptibility testing in future. And end of the culture and drug susceptibility testing, we will ship the desired isolates to Cameroon for further analysis. And finally, we analyze data and report writing. To perform this study, we have several challenges. The main challenges are the procurement delay, that is due to the COVID pandemic. And also we have hampered for other activities due to the countrywide lockdown for 3 months. So I hope at the end of the study, we'll find the missing piece in the puzzle of successful detection of additional isoniazide resistance mechanism. So I'd like to acknowledge our collaborator from Cameroon and from Lebanon, and also for Foundation Meru. So I'd like to extend my gratitude to the donor, Foundation Meru, and also the co-donor for ICDDRB. Thank you.
Thank you very much, Dr. Mohammed, and I hope all the challenges will be resolved soon and you can continue with the next steps of this very interesting project. And let me invite Professor Manzoor Hamza, who is the full professor of the Lebanese University and has been our generous host on the last Gabriel meeting. So he will be presenting the same project from the country Lebanon perspective.
Good morning. As explained by Dr. Valerie, the project has 3 aims. In Lebanon, due to the economic crisis, we are only involved in the aim 1, where we have to only isolate the isoniazide resistant isolates and send them as viable strains to Cameroon. In Lebanon, we have 2 types of isolate involved in the study. The first type are isolate resistance to isoniazide and frequently investigated molecularly for resistant mechanism. Indeed, we have among these pool 4 isolates of interest that are resistant to isoniazide phenotypically, but with no molecular resistance mechanism identified by DPLEX. By the way, DPLEX is a deep sequencing assay interrogating 18 main gene targets associated with resistance to first and second line drug resistance of Mycobacterium tuberculosis, of which 4 involved is in isoniazide resistant CAT-G, EHPC, INHA, FAB-G1. These isolates were collected during a nationwide study from June 2016 and November 2017, and carried out as part of PhD of Dr. Salam Al-Ash'ar, supervised by myself and Dr. Philippe Sapli at Pasteur Institute in Lille, with many published articles. Nature of Lebanese isolate involved in the study. We have 2 types. Type 1, 4 isolate of interest that are resistant to isoniazide phenotypically, but with no molecular resistance mechanism identified by DPLEX. DPLEX is a deep sequencing assay interrogating 18 main gene target associated with resistance to first and second line drug resistant of Mycobacterium tuberculosis, of which 4 involved in isoniazide resistant CAT-G, EHPC, INHA, and FAB-G1. These isolates were collected during a notion, c'est déjà dit, excusez-moi. Nature of Lebanese isolate involved in the study. Type 1 isolate, no drug resistant associated mutation detected despite high coverage in CATG, NHA, FAB-G1, or AHPC bideplex. A single case of ENH resistant phenotype had an unpredictable ENH result by diplex MAC-TB due to low coverage of corresponding gene target by diplex. These 4 isolates were from sputum, pulmonary tuberculosis, 3 Syrian refugees and 1 Lebanese patient, 3 new cases and 1 case of a previous TB patient. All are cured. Type 2, 150 isolate with no drug susceptibility testing collected from December 2017 to June 2018 from Lebanon. You can see in this picture the distribution of this strain. Spotlight on type 2 isolate. I think you have the first slide given to you, Valerie. Okay, I pass for the. We have 150 strain in our collection now in Tripoli in North Lebanon. We want to receive all media culture and antibiotic for sensitivity testing to start the testing in our laboratory, and after detection of isoniazid resistant, all strain to be sent to Cameroon in the laboratory of Dr. Valerie. Difficulties, double army in Lebanon, severe economic crisis and COVID-19 crisis resulting in slow communication process with manufacturers to get quotation, difficulty to ensure our fund to buy the reagent waiting for the reception of the Gabriel funds, difficulty sending the alive strain to Cameroon. The situation now, we obtained from our Ministry of Public Health the official paper for the donation of reagent from Cameroon. We are waiting now the reagent. And thank you.
Thank you so much. Now we have time for a few questions for the presentations. Yes, please, Philip.
So this is a question for Valerie, especially. So I would really suggest two things. One is to prioritize as well search for mutation causing INH resistance beyond CAG and INHA in AHPC and FAB-G1 genes. As mentioned by Monzer, these are genes that are known to contain as well INH resistance mutations. So I would prioritize those ones before the other ones that were mentioned. And second thing is to expand the strain set that are susceptible to INH, because for the moment I could see that this is a restricted set, and that would enable you to detect possible phylogenetic SNPs that are associated with INH resistance mutations. But these ones should be found as well in INH susceptible strains. So you have to have a good control group to detect these ones and to avoid making mistakes and inferring that this is an INH resistance mutation.
Yes, any feedback from the presenters? Yes, please.
Just one comment and one question. So comment for Liben. You have the possibility now to perform the test of phenotypic and genotypic in the LNR in Beirut. I think it's more efficient than to send the strain in Cameroon. And my question is about the cutoff for INH. you mentioned what is the level of the cutoff, 0.1, 0.4, 1. It's very important to determine the sensibility of the strengths. Thanks.
Would you take the question, any of the presenters? Or I would suggest, if it's not yet defined, yeah, there is a capacity here to work on that. Yeah. Thank you so much. Thank you. I think we need to move, and I want to check, Florence. So do we proceed with the video conferences as they come by time now, or
We can
continue with Josette? Yes. Thank you. So we invite now Josette Najjar Baled. She has a biology background and holds a Master of Public Health and PhD in epidemiology from University of Lyon. And Josette will be presenting TB management and laboratory capacity building in emerging emergency setting, accomplishments and lessons from the Lebanese crisis. Floor is yours.
Thank you. So I'm very happy to be back to Les Pensières, and thank you again for Florence and all the team to proposing for us to be with you physically for this Gabriel meeting. Knowing that the last one took place in Lebanon 2 years ago in June 2019, before the crisis. So I wanted to bring a little bit of positive vibes, even though the context of the Lebanese crisis with IS at the end was complex, but was not a limitation to be able to accomplish some of the things. So, alors, comment ça marche? Ça? Non, verte. Okay. Okay, back. Okay. So I will talk a little bit about the retrospective and then the work that we have done in the peacetime. Then talk a little bit about the crisis consequences and then the accomplishment despite the crisis, what we have learned and what will be next. So without going into a political description of the context, because it will be very complex and it's not our mandate, just to remind that in 2011, the Syrian conflict started, generating a big displacement of Syrians all over the Middle East. And Lebanon was one of the countries that hosted progressively almost 1.5 to 2 million of displaced. We call them displaced and not refugees because Lebanon have not signed international resolutions. So what happened is the country became the country where we have the highest displaced per quota of habitant. So 4 million plus 2 million, 6 million, in addition to the refugees, Palestinian, and then migrant workers that are in the country. In addition to this, there was a presidential void. So for almost 2 years and a half, there was no president and no government. And arriving to 2019, prolongation in the parliament. So all of this is only to describe a little bit the context where Fondation Mérieux, in parallel to this, started thinking about supporting the TB activity. 2019, you see this, was October 2019, the beginning of new disruption with social and economic crisis. Then the government resigned. And as Marianne presented yesterday, in March 2020, beginning of the COVID pandemic in Lebanon. August 4, 2020, the blast, Beirut blast, the port. And then we started with a nightmare where the money devaluation, the political and economic crisis leading into 2021, this year, where the World Bank classified the economic crisis in Lebanon as the third historical economic crisis since the Second War. So this is the context. Then, in parallel to this, Fondation Mérieux in 2011, as Monsieur Mérieux presented, inaugurated Laboratoire Rodolphe Mérieux at Université Saint-Joseph de Beirut, based on the fact that there was no Laboratoire Rodolphe Mérieux in the Middle East and no BSL-3 setting also in the country. And in fact, after, in parallel to what was happening in the country, the Syrian crisis, we wanted to expect that this lab would play a major role in terms of public health. So in 2017, there was a decision in changing the governance of Laboratoire Mérieux, and also to the decision to work more in synergy between the laboratory and Fondation Mérieux. Marianne became the head of the lab. Also, Dr. Marianne Antar, who probably is online, is the manager of the lab, took in charge the lab. And then we started in 2018 and 2019 to work on setting the work of TB in Laboratoire Rodolphe Mérieux. And then the second phase is I will talk about this one. So now I will focus a little bit of what we did in 2018 and 2019 after the decision of investing. So where did we start from? This was the Lebanon profile. It's a low incidence country for TB, and it would be a good candidate for a TB elimination, for example. But despite, with all the problem that we were facing, this is more or less the situation. Probably we will go for 14, and in 2021, it is difficult to consider this as a bad indicator or good indicator, but because it could be that the fact that a national TB laboratory has been put in place could improve the detection also of TB in the country. So what did we do? So first, we were, as always, Fondation Mérieux works with the ministries of health in the countries, and our first question was to validate and identify the need. So it seemed that based on the Lebanese National Strategic Plan for 2017-2018, the need for elimination for tuberculosis, this is one, and then a recommendation of identification of a national referral lab for TB. So there was no designated lab. It was a good opportunity to open this BSL-3 lab and to dedicate one of the labs for this. The second step was to upgrade the infrastructure to make sure that all the flow system, the airflow system was still valid, because the lab was built in 2011 and didn't serve for this. And then we had to equip fully we have two BSL-3 in the lab, one dedicated for TB, and of course procure all the reagent in order just to launch the first phase of the work. And then the third step was recruiting and training staff, setting with Laurent a huge work on the process, the SOPs, and starting for 6 months a pilot's work where we see how everything is working between the hospitals, between the NTP and the laboratory. And by June 2020, it was the time where we did validate that everything is okay and we can launch the activities. So we continued working on OPH to writing SOPs beyond the referral between only NTP and the laboratory, but also the hospitals. And we were asked to contribute to the national review programs and to all the audit missions of WHO and GLC missions. And for information, since Lebanon is a low burden country, he was not eligible for Global Fund money. But since 2014, with the Syrian crisis, Global Fund is financing International Organization for Migration for what we call the Middle East response for emergency regarding TB, HIV, and malaria. And after this 1 year work between 2018 and mid 2019, the lab was designated National Referral Lab for TB. So we continue to work on the supervision, corrective action, starting to training the staff of the national program. And then the crisis started. So we were at the end of this cut between the situation in the country and what we have planned to do. So one of the crises was COVID, with the impact that many of you have already presented. But for TB, more precisely, there was a shifting of the activities in the health facilities from TB to COVID. The fact that clinicians and the labs were overwhelmed. And there was also, we didn't talk about it, the stigma related to the disease, because patients were afraid to say that they were sick because the stigma around COVID at the beginning. So what we did is that we tried to join latent TB and presumptive cases a screening along with COVID testing. We try to maintain a dedicated time for TB in the National Referral Lab at Laboratoire Adolphe Mérieux. And we continue to train NTP, but this time mainly on infection control measures. This way they were not afraid to be in contact with the patients. And on the other hand, after 2020, then we reversed. We now train them to be able to do the COVID-19 sampling at the NTP, since the WHO recommended now to test COVID-19 for TB patients. And we started screening the COVID-19 in parallel. So these are the pictures of some, you have seen it on the social media, on TV, of the blast, but these are the pictures of the national TB program, and these are the pictures from the National Referral Lab of Laboratoire Adolphe Mérieux. So you can imagine the situation after the 4th of August, and in addition, around us, 4 university hospitals in Beirut sector heavily damaged. So what we had to do is very quickly to be able to put again the National Referral Lab operational. So in 15 days, it was all in place to be able to start again the diagnosis. This was the picture the second day. This is Dr. Hiyam Yaoub, the head of the National TB program. And since there was no treatment center anymore, she was here just in front with our colleagues from IOM under the tree, treating the people. And, you know, the drugs were saved, because at on the same night, they sent somebody and they were able to save the drugs. And she was doing the job under the tree without any center. IOM was able, with the Global Fund, to relocate them for a few months. And we, Fondation Mérieux, also supported the settlement of this lab in the temporary location. And then positive things, in June 2021, the new center, the same place where everything was damaged, was rebuilt, and it was inaugurated. And Fondation Mérieux also was part of this investment, rehabilitating fully the lab of the National TB Center. This is a picture a little bit of how today the services are organized. I will go quickly for the time. As many you heard from many colleagues, with the financial crisis, there are difficulty in the procurement, in the rise of the prices, and then our main concern is the access of diagnostic for the patient, and the additional point, it's challenging in maintaining the staff, because as you know, people would like to leave. So what we did, we anticipated at the maximum in terms of stock, reagent, and consumable. So we have never had any interruption in terms of access. And so Dr. Minzer, if you have problem in the DST testing, you can refer them to the National Referral Lab, because with the support of the other partners, we are able to maintain the activity for now, since we have the stock for now. We wrote some what we call procédure dégradée in order to adapt the algorithm and to be able to be sure we not having any stock interruption. And voila. So at the end, what we can say is, in 3 years, we were able to change some of the numbers. For example, in the extrapulmonary TB confirmation in the country, it evolved from 1 to 35% on microbiological confirmation. This is an example. Despite all the problem, in 2019, in a low burden country, we identified 4 XDR, which was really a very complex situation. And now, unfortunately, we are detecting every year 1 to 2 cases of XDR. We were able to increase the referral despite all these problems, and you see the evolution. And the positive things that we started at the beginning with only NTP, and now the hospitals are starting to referral. If you see the compliance, we were able, by training the NTP, to improve the compliances also in the referral. And now we will have to work in 2022 on the hospitals. We worked a lot on also during the crisis on the data collection tools. We saw it was very important for TB and for COVID. And now we will be going for the electronic data reporting between the NTRL and the NTP using DHIS2. So this is all now done, and training will be next week. And this will be positive in order to have time, on time, the result without having to send it or the information about the patient between the lab. And in 2021, this has been just released, the new algorithm and recommendation for this. A quick word on latent TB, because I heard a little bit about this today. Also, we were able to implement a national latent TB study with almost 1,000 recruitment, but really focused on high-risk groups. High-risk groups are migrants, contacts, and professionals, healthcare professionals who work in infectious diseases, pneumology, or high-risk area. And this will help us, this will be for 2022, elaborate the new recommendation for latent TB in the country. Okay, so some of the lessons learned. So I think it's very important to have this need analysis before starting, to be sure that we have a roadmap, to invest if you have a peacetime, if your country invest in this peacetime to build transversal capacity. We were able to, Marianne presented to answer for the request of the Ministry of Health for COVID on March 2020, because we were already ready for something else. So the shifting was easy. And because the capacity building done was not only for TB, it was done for a laboratory capacity building. Of course, setting long-term partnerships. So we're happy now that even though it's a low burden country, the partners are now interested in investing in this program. Targeting expertise and not service delivery. This is not to quote Laurent Raskin, but this is important also to make sure that the system and the clinician doesn't see the lab as a service delivery, but also a partner in the expertise. And maintaining the quality all the time. We didn't talk about it a lot in this meeting, but many of our labs are engaged in ISO 15187 for the quality, and it helped us also a lot to be able to stay professional in the crisis. So what are the next steps? So the first one, and this is not easy, is resisting. We don't know how many times the crisis will continue, but we'll try to resist. And the second one is we're starting to support regional effort. We have been asked by WHO and other partners to start to help other countries based on what has been accomplished in Lebanon. And this is to thank all the people and from the different institutions for their support for this work in this consortium. Thank you.
Thank you so much, Josette. Thank you. It was very inspiring, at the same time difficult, but inspiring, how through dedication of the staff and the proper international support can really not only keep the important public health activities, but also help to scale it up even during this such a difficult time. So wish you all the best to your country. And coming from Georgia, the territory of which is still occupied by Russia, I know what the crisis means and how difficult it is really to keep going. So yeah, thank you very much. And maybe comments from the audience. Yes, please.
Well, just to say that it's very inspiring. I met an Estani in one situation that was very hard. She was doing her PhD in Emory in Atlanta, right? 14 years ago, and she was there, and the family, the kids, they were in Georgia, and they had one political problem. And I remember she was like in a hard situation and didn't know what happened with the family. And it's nice to see her today. And I guess for Lebanon, in some years, we'll have the same. You'll have people more committed and engaged to go up.
I hope so. I hope so.
Just to explain, we have in our collection this strain collected between 2017 and 18 in our collection. Also, we are in Tripoli, in North Lebanon, recognized laboratory by the Ministry of Public Health for TB. Okay, we work as research work and not as diagnostics in this period of this study. Okay.
Yes.
For these reasons,
No, I was suggesting if you have problems because I didn't say also what was interesting is when we had the nomination, you know, for the new drugs, it is very complex for a low burden country to be able to have them for bedaquiline and idezolide, but we were able to have them. So this is a good news to know that we were able to have them with the support of IOM and Global Fund. And now we are able to do everything, and all the concentration and everything is already done. So we can offer to help if there is any need.
Excuse me for the disruption in my presentation because Valerie put the first version of my presentation, and then I have the second one.
We move on with the online presentations. And for me, it's a real pleasure to present Jerry Elner. I am Delia Goletti. I don't know if you remember me. We met in the United States almost 25 years ago when I was at NIH. And for me, you have been the person that taught me about TB, HIV co-infection with, of course, Dr. Pape. But for me, you have been very inspiring, and you have been a teacher, and I've been thinking of you many times in my work. So it's a pleasure to introduce you. You have been in faculty positions at Case Western Reserve University and Boston University, and then you have been the leader of several studies on TB HIV, and at the moment you are a principal investigator of TB RIC. And today you have a 10 minutes presentation, and you will present about report network overview and focus on biomarker activities. Thank you, Jerry.
Thank you. Thank you for that introduction. And I will remember your visit to Cleveland. And I would have said it was 30 years ago, but it's been quite a while. And it's great that we've both since then been so active in the world of TB research. So it's a pleasure to present on the behalf of the Report Network to the Gabrielle Network. I think there's a lot of potential for collaboration. Report is the regional prospective observational research on tuberculosis network. And this originated as an idea from the National Institutes of Health. And currently there's a consortium of 6 countries. And they were kind of phased in, if you will. India in 2013 currently has 9 sites throughout the country. South Africa, Brazil, China, Indonesia, Philippines, all low and middle income countries which contain over 50% of the TB cases in the world. And the idea here is to have a network, in fact, which will allow you to study infrequent endpoints in tuberculosis using common data standards and SOPs. And this is all really organized for the purpose of developing a resource, a biorepository that can be accessed to discover and validate TB biomarkers and vaccines, and also could be used to develop endpoints for drug trials, etc. Let's see, can someone, let's see. So the countries are going through a transition from phase 1 to phase 2. And at this point in time, we're organizing around retrospective studies, beginning with retrospective studies using the samples in the biorepository and moving on to prospective studies. And the major recruits are TB patients and their household contacts. So there are a few common threads that tie report together. First, there's bilateral funding. So, for example, in India, the funding for the activities in India are through Division of Biotechnology of the government of India, and the funding for US activities and for much of the collaboration comes from National Institutes of Health through CRDF Global. Currently, the central organization, or the TB Report International Coordinating Center, which I head, is investigator run. And this gives us access to research fundings, which we can apply to some of the really novel approaches that are possible through report. As I mentioned, the sites are linked, all are involved in a common protocol where we pre-specify the clinical data, the laboratory specimens, the SOPs, and quality control of the data for later analysis. The capacity of report, of course, is to address diversity of human and bacterial populations and to study infrequent endpoints. Just recalling that in some of the initial studies of biomarkers of progression, the funding was largely from the Gates Foundation, and there's a huge amount of funding to do a proper study looking at biomarkers of progression from infection to disease. But in fact, we have the specimens that someone with a good idea can come to us and access, and this saves decades and a lot of cost. The biorepository is, I think, probably, there are large biorepositories throughout the world for various diseases, most of them not infectious diseases particularly. But for example, in Report India, we have 250,000 specimens, including sputum, saliva, oral secretions, hair, nails, urine, stool, you name it. And of course, this is of value because particularly when we're getting to areas like diagnostics, we want to move away from sputum-based studies. Lastly, and this wasn't in anyone's planning, of course, was that the START report was long before SARS-CoV-2 pandemic, and now it's hit all the countries where we work. So this is really ideal for a study of co-pathogenesis of TB and COVID-19, since we have recent historical controls. So it's complicated, and we won't go through this, but we have some of support from some of the leading international investigators on tuberculosis. And a lot of our function relates to harmonization of data with insights and across sites. So the administrative piece and data piece are extremely important to us. And much of that is effected through collaboration with Vanderbilt University, which are leaders in data harmonization of networks of this kind. We have a matrix structure with scientific working groups led by content experts, and the executive committee was representative of our consortium. So what can we do? Here's an example. We can characterize and validate biomarkers for individualizing targeting prevention treatment after adjusting for epidemiologic and clinical confounders. So let's talk about biomarkers predictive of adverse treatment outcomes, failure, relapse, and death. We have in our biorepository, in our clinical data set, over 8,600 active TB cases. So this has led to a large number of relapses, failures, and deaths. So we can do a definitive study and even internally validate at different sites the biomarkers that we develop. And of course, we can look at epidemiology of progression, as well as treatment failure, treatment response biomarkers, mycobacterial factors, predictive models, and also whether how important adherence is as a confounder of a treatment outcome. So what are the challenges? Data harmonization is complicated enough within a country, within multiple sites, but between countries, it's challenging, but we'll only be able to realize a vision if we can harmonize the data and analyze it together. We need to go through a complicated approval process across cultures, MOUs, IRBs, data sharing, shipment of specimens. And important for this presentation is that we're relatively new resource and often not adequately recognized as a potential again, source of specimens that will accelerate your own work. Now, I think it's important to note also that we're an observational cohort studying a public health problem. And in countries and internally, we'd like to move more into interventional research. We have the infrastructure, we have the populations, and I think that report is ideal, for example, for a diagnostic network, a treatment trial, vaccine trial. In India, we are involved in a trial of VPM 1002, a recombinant BCG for the prevention of relapse of tuberculosis. And of course, each of our countries at various times has been hit by COVID-19, disrupting the orderly process that we had planned. So report is, I think, a novel and I would say a bold endeavor. Wasn't my idea, actually it's a great idea with unique features such as the common protocol and bilateral funding. And it really is in the hands of the investigator to mine the database from biorepository to develop new tools for TB control. And of course, our ability to do so will be in part determined by collaboration outside of the inner sanctum of the leadership group in EC. So I'd like to acknowledge that Sudha Srinivasan and Peter Kim have developed this concept and seen it through and turned over the leadership to the investigators, for which we thank you. And of course, investigators throughout the world, the staff and the patients. So thank you for inviting me, and nice to see you again, Dr. Gulati.
Thank you, Jerry. There is a question from the remote part, if the technicians can help.
Yes. What is the percent of children in the report cohort? We actively enroll children, and our ability to do so is variable by site. You know, I would say that about 20% of the report cohort are below the age of well, let me back up, probably 30% below the age of 15 and 10% below the age of 6.
Thank you. Is any questions from the audience? If not, thank you very much, Jerry, and hope to see you in person soon.
But let's not wait another 30 years. Not a good idea. Take care. Thank you all. Thanks for inviting me.
And we continue with the honor to have Professor Padmini Salgame. I hope to pronounce your name well. She is a professor of medicine and the associate director of the Public Health Research Institute at Rutgers in New Jersey Medical School. She led several very important studies on signatures for TB, and today she will report on the biomarkers activities. Thank you.
Thank you for the introduction, and thank you for the invitation to share our plans for the biomarker studies. So as Dr. Elner mentioned, so this is part of RIC, and the idea here is to to look at biomarkers in the entire consortium. But before I get there, I just want to say that this is more our plan of what we want to do rather than a presentation of data. So as most of you know, TB is a spectral disease. Following infection, the outcomes can vary. Do you all see my pointer? I guess so. So as we know, the spectrum or the infection outcome is varied. Of course, at one end of the spectrum is individuals who progress to TB disease, and at the other end is individuals who either through acquired immunity or innate or adaptive immunity have eliminated their infection, and then you have your quiescent latent infection, and then incipient to subclinical disease moving to advanced. And of course, the treatments for these various infection states in the host is very different. Of course, you treat with multi-drug to advanced TB, with preventive therapy and controlled quiescent latent TB. And of course, no treatment if you have sort of cured your infection. And again, there are many different methodologies available to diagnose TB. There's tests that look at bacteria itself, tests that look at the host, and a number of these tests can either diagnose one or many more states of this spectrum. But what I'd like to sort of talk a little bit, and the plan for what Rick is doing is to talk about treatment failure. So if you go back, I mean, following cure or treatment of TB patients, the outcome is not always cure, but there is treatment failure and relapse. So in previously treated TB who have been declared cured, and if treatment is completed, if there's diagnosis with bacteriologically positive smear or culture TB, is referred to as relapse cases. If a treatment is started and and this treatment has failed in the individual and they have to be restarted on retreatment, this is referred to as failure. And of course, a default where individuals do not adhere to their treatment. So the point is, can we diagnose even before individuals relapse or fail treatment? Are there biomarkers available that would predict these outcomes in individuals? So there are a number of biomarkers that have been reported that have been associated with treatment failure and relapse. And we, as part of the report consortium, would like to sort of validate in the large cohort that we have whether these biomarkers that have been published in small studies that have not really been validated, there's an opportunity here to determine, to validate these biomarkers. So really the overall goal is to identify biomarkers predicting recurrence-free cure, that then of course, would that be feasible for a point of care diagnostic? And so the objectives then are to try a couple of different platforms to test these biomarkers. And one of them is to use the Fluidigm quantitative RT-PCR platform, testing many different known biomarker signatures that predict cure versus unfavorable treatments. We have also begun to use another platform called the NanoString platform as an alternative to transcriptomic. The NanoString encounter technology is interesting. It's an amplification-free digital detection platform where you don't have to really, it's not an RT-PCR based, so there's no amplification. There's no, you don't have to transcribe the cDNA. And so it directly measures mRNA transcripts and does it with high specificity. So this is something we have introduced in some of our report studies, and would like to use this platform as an alternative transcriptomic way to look at gene expression. And then, of course, we want to test RNA treatment response signatures in multi-drug resistant TB, and also test plasma cytokine treatment response signatures using multiplexed approaches like Luminex. Another test that we would like to add based on some recent studies is to use the T-cell activation markers on cell surface itself as a means of predicting treatment outcomes. And of course, then is to be able to come up with a model to compare these various tests and see if we can come up with an individual or a combination of tests that would predict treatment outcome. And I think this is really necessary, and the report and Rick allows us to sort of test a number of available signatures. This is just a slide that I took from a review article that shows that there are many different biomarkers that are out there. For example, you have this, from an analysis done using PubMed, EMBase, and a number of other literature bases, is that there are a number of different biomarkers. In this case, they showed 399 biomarkers. But only, if you look, only 12 of them have really been validated in a prospectively designed study in a blinded manner, and only one biomarker-based test has really been reviewed by WHO. That's the LAM and urine test. So clearly there is a need and to verify these large numbers of biomarkers that have been sort of discovered and not really well validated, and Rick gives us that opportunity. And so so this is utilizing a biorepository. This just to re-emphasize what the tests are, that host-based tests that will be performed in these samples that we have in the biorepository. But I also want to add that in addition, we would also be looking at some biomarkers that are bacteria-based, including small colony variants and MICs. And these assays would be done at different time points and at various assay sites where the expertise is available. So that's really our plan, and we hope to get this off the ground very soon. Just want to acknowledge Rick for the biorepository that's available. There's a huge biomarker committee that's involved in planning and executing and hopefully implementing these assays at the various sites. And of course, to our leaders from the NIH, Drs. Peter Kim and Sudha Srinivasan, for really supporting this whole program. Thank you.
Thank you for this beautiful overview of the biomarkers plan in this project. Is any questions from the audience? I think that Jonathan Hoffman.
Thank you very much. I would like to know if you have any plan to develop a point of care test using dry blood spot. Is it in your pipeline, dry blood spot?
I didn't follow you. What was the test? I can't hear you too well.
I would like to know if you have in your pipeline of biomarker investigation, if you plan to use dry blood spot biological sample.
You raise a very interesting question. I think Jerry and I have been discussing that in another context. We really don't have an assay ready to go, but it's something we could think about. Jerry, do you want to comment on?
Well, the point has been made that how are you going to operationalize a host response biomarker such as host response cartridge or 3-gene at the point of care, and because if it requires that you already have instrumentation, it's not going to be point of care. So I think there's a plan to collect blood spots at point of care and then transport them and hopefully to extract the RNA. I don't think PAB-Mini, we have blood spots as part of we have everything else.
Yeah, we don't. Yeah,
but we don't have blood.
We don't have blood spots. Yeah.
Okay. Thank you.
Those blood spots may be challenging with RNA-based gene expression, but it's possible if you can fix it. Technologies like NanoString do a good job of detecting mRNA even in fixed samples, and so there is room to sort of work on that. Yeah.
Thank you very much for your presentations, both to Professor Elner and Professor Salgame, and thank you for your time.
Thank you.
Thank you.
I think now we have ended the session on tuberculosis. I would like to thank all the speakers for the very nice presentation that we had this morning, and also the two chairs. Thank you very much, Delia and Nestani. And so now we will move on the Young Scientifics Award ceremony. I think the young scientists are waiting to know the result of the competition. And so I'm asking the members of the jury to come and to give the result of the evaluation and to give the prize of the two winners of this award.
Je vais venir proclamer ici. Hein? Mais ok. Ok, je viendrai proclamer ici. La pression, hein? Mais comment tu as eu les noms? Les diplômes étaient imprimés. On m'a mis que 2.
Je sais.
Non, ça va.
Okay.
Allez.
C'est où ça? Au milieu. Masque. Je peux le mettre sur le masque. C'est vrai que les photos, c'est mieux. On peut mieux publier.
The winner is so you can.
Si. Ma pièce et mes papiers. Okay. Thank you very much for the confidence given to evaluate this great work of our young scientists. All the presentations were wonderful. I could insist on this term. However, in the context of scientific competition, we have to rank them. We discussed a lot within the jury, but I can reassure you that we didn't need to fight because because we rely our decisions on objective criteria. Those criteria were 4. The first is the scientist's knowledge, including the involvement in the work of the scientist, the contribution in the current project, and the ability to defend it, including the response to the question. And finally, the perspective of the work. Based on these 4 criteria, we rank the 5 candidates, and the second position goes to a study. It is a study which which works on antimicrobial resistance. The study is titled Evaluation and Monitoring of Prevalence of Extended Spectrum Beta-lactamase Producing Escherichia coli in Madagascar, the Tricycle Project Year 2. This project is led by Tiavina Rosolofo Yarison. Welcome.
Thank you.
And apologize for the wrong pronunciation. So the top one of these 5 projects goes to a project which is based on tuberculosis. Multi-country evaluation of risks 6, a 6-gene blue transcriptomic signature for tuberculosis diagnostic and treatment monitoring. So we have our 2 winners of Young Scientist Award. What is the second? They have their diploma. I think that we'll give them. I could give you. Yes.
Congratulations. Congratulations.
Very good work.
Yeah.
Okay.
Okay. Thank you.
Bravo. T'as une pression? Merci, Marc. C'est pas habitué.
Okay. So this is time for the concluding remarks. So first of all, kudos for all of you for the great party we had yesterday night. No need for any capacity building on this. You're all seasoned on samba and other Brazilian dances. These last 3 days have clearly shown the fantastic added value of in-person meetings to foster lively discussions, to settle ongoing difficulties that we inevitably come across during project implementations, and to establish new collaboration, and this is the most important. So we had a very rich session on diverse topics, and since I have the memory of an oyster, I took a few bullet points. So regarding the COVID-19 session, we had an enlightening lecture by Bruno Lina on where we stand and how we are going to live with SARS-CoV-2 pandemic during the coming years. We had also very interesting discussions sparked by the presentation of Bill Papp regarding the unexpectedly low incidence of severe COVID-19 cases among several vulnerable communities. And this raised the opportunity to mount collaborative projects, in particular regarding longitudinal seroepidemiological studies in different countries, in order to better understand the underlying biological or sociological basis of such an observation. So clearly, I think that this is the kind of discussion that we wanted to have during the meeting, and clearly that could benefit, leverage on the skills and the complementarity of the members of the Gabriel network. So another important issue that could be addressed in a synergistic fashion within the Gabriel network, and which has been largely discussed during this session, is the epidemiosurveillance of COVID-19 variants. So we could leverage on this kind of project and the many funding opportunities for this topic through international programs to strengthen the NGS and bioinformatic capacities of the network, which could address unmet diagnostic and research needs well beyond the field of COVID-19. However, I think that we should be well aware that NGS platform cannot be set up everywhere, as it not only requires a critical mass of experts on wet and dry lab activities, but also a sufficient number of relevant projects and questions that could strongly benefit from such sophisticated approaches and could justify the important costs incurred not only to set up, but also to maintain such facilities. Regarding acute respiratory infections, I have been particularly impressed by the presentation by Liz Greenslade, which highlighted not only the devastating impact of pneumonia on the lives of the youngest and the oldest, but also on the lack of awareness of major international partners regarding the need to properly tackle this major public health problem and support activities on this topic. During this ARI session, I also noticed, beside the presentation of many promising results from ongoing projects and initiatives involving partners within and outside Gabriel, the opportunity to leverage on the skills of several Gabriel members to implement a new multicentric project on pneumonia. The AMR session was not only an opportunity to present the AMR roadmap of the Fondation Mérieux, but also to present the latest results of the One Health surveillance project implemented in Madagascar and a new collaborative project between Cameroon, Brazil, and Madagascar, supported by a seed funding from the Fondation Mérieux. It was also the opportunity to launch a discussion on the future AMR activities that could be implemented within the Gabriel network and which could take advantage of the recent partnerships that have been established with the Jean-Yves Madec team. Although I could not attend the discussion, I heard that several collaborative tracks have been identified, and this will be an excellent starting point for future discussions that will be steered by an ad hoc working group in the coming months. We had, during the TB session held this morning, a very clear presentation of the TB roadmap of the Fondation Mérieux, relying on the implementation of several projects on TB biomarkers and community interventions already implemented in Madagascar and Cameroon, and soon to be implemented in Bangladesh. This session was greatly enriched by several presentations by highly prominent speakers reviewing the challenges and promises on TB diagnostics and algorithm to guide pediatric TB treatment, presenting an interesting international consortium on pediatric TB coordinated by RID, and describing new NGS approaches to diagnose MDR and XDR TB. As I mentioned during my introductory talk 2 days ago, we really need to work all together on the best way to leverage on the Gabriel network to establish new partnerships with major international players, strengthen the network capacities and visibility, and raise additional funds for diagnostic and research activities implemented by each Gabriel members. As already discussed, this will probably require a new mapping of the activities, skills, and need of Gabriel members that will need to be customized according to the topics or indication we wish to highlight: AMR, TB, emerging pathogens, and so on. So we will work during the coming weeks on the questionnaires that could be sent to all of you to perform these surveys. And we hope that we will rapidly develop appropriate tools and documents that could be rapidly used to communicate on the Gabriel network with our existing and future partners. So I would like to thank you Thank you for all the fantastic job you have done and you are doing, for your enthusiasm and resilience, which allow you to work in very difficult contexts and with limited means. I thank you also for all the fruitful discussion we had and the nice moments we spent during the last 3 days. So I wish you a safe trip back to your respective countries and look forward to meeting you again, either during field missions or at least during the next Gabriel meeting. Thank you very much.
So thank you very much for all of you, the speakers, the participants that are also online. And I would like to give a special thanks to Marie-Charlotte. So please, Marie-Charlotte, that she has made a great, huge work for the organization of all the logistics, because it's during this time that is very difficult with the flight, the COVID issue, there are a lot of difficulties. So thank you very much. I would like also to thank the Pensière, the team of Benedict, for their incredible also host. It was very wonderful to be here after a long time without any travel. So thank you again. So I wish you a safe trip to go back home, and hope to see you in next few months doing our different travels in your respective countries according to the research projects that are going on. So I hope that we can travel now next year. Thank you.